Very good morning, everyone. So, after yesterday's sessions and today's yoga, we will start our session with the neuro rehab introductions and further development. And for that, I would like to invite Dr. and Professor Nirmal Surya sir. Sir is a consultant neurology at Bombay Hospital and Research Center, New Marine Lines, Sefi Hospital, Knockhout Police Hospital, Mumbai. When it comes to awards and affiliation, in Sir's name, there are many awards and affiliations as well. Sir is a chairman in Neurocenter Mumbai, founder, trustee, and chairman of Epilepsy Foundation India, founder, president, IFNR, Indian Federation of Neurology since 2012 onwards. Sir is a past president, Indian Academy of Neurology, president of Indian Stroke Association, treasurer at Neuroscience Academy of Telcare and Artificial Intelligence, secretary and general World Federation of Neurorehabilitations, president in Asia Oceanian Society of Neurorehabilitations, member of Digital Strategy Subcommittee on Chair and Developing World Forum, WFNR. He is a CEO at Indian Confederation for Healthcare Accreditations, ICHA. Past presidents of MAN and BNA. President of 10th WCNR 2018, Mumbai, India. Commissioner, Lancet Commissions of WHO for NR, member of Primary Workforce of World Rehabilitation Alliance, ambassador of One Neurology. Sir's key interest is epilepsy, stroke, and neurorehabilitation. Sir, we welcome you.
Good morning. It's a privilege to have a neurorehabilitation session in any conference of neurology. Could we have the presentation? Today's session on neurorehabilitation have a multidisciplinary team, and we would highlight what is the importance of neurorehabilitation. And we will also get into the pulse in neurorehab. We will discuss about the planning in neurorehab case-based approach. We'll also have swallowing assessment and role of ultrasound in the neurorehabilitation. So we will cover a wide range of neurorehab. Each speaker will be introduced before their talk. May I have my introduction presentation? It's not seen here. Okay. Will this be working? How do I go? No, I have a PPT here. You need to put my PPT. Hito, please see that. The first lecture, introduction, importance of neurorehabilitation. Yeah, that's one. But it's not seen here. So how do I play this? It's not here. Huh. Is this laptop is not connected there? That, would you give me a remote? Is this working? No, I see, but how do I move? And then if I have to speak from here, then I don't have the mic, so you'll have to give me the collar mic.
is green
No,
one.
no, that I know.
Yeah. Now it is changing.
Yeah, it was not working, that's what I've been telling you.
Okay.
So this is our everyday job.
Yeah.
So you don't have to tell us to move forward or backward. All right. So what is neurorehabilitation? It's a specialized therapy designed to aid in recovery of neurological function following damage to the nervous system, often due to stroke, traumatic brain injury, spinal cord injury, or the neurodegenerative disorder. And our goal is to improve the function, reduce the symptom, and enhance the quality of life of the patient. You all know that globally there are 2.41 billion people with disability, and this was 2019 data. In 5 years, it must have increased by another 10%. The number has increased by 63% from 1990 to 2019. The Southeast Asia has highest need of rehab services, 593 million people. And India is among top 5 nations with highest number of people needing the neurorehabilitation with least amount of expertise and facilities available. The significance lies in ability to enhance independence of and elevating the quality of life, effectively managing the symptoms. And this rehab program has to be tailor-made, and they have to be specially for those with specific neurological disability. So patient often experience improvement there in overall function, reduction in symptom, and enhances the well-being. So it is very important that neurological rehabilitation is highly individualized, and as per the requirement, it should be modified. Assessment and personalized approach are the crucial in determining the most appropriate and effective course of the treatment. What are the concept of rehab? So if you look at the concept, they can be, it differ from acute care. Patient entered a program of goal-oriented multidisciplinary rehab program, differ from rehabilitation in post-acute setting, and hospital-based following definite care for resuscitation. So each setting, the programs could be different. What are the principles of neurological rehabilitation? We work on neuroplasticity. There should be individualized approach. Try and get maximum movement, promotion of normal movement and function, correcting and varying the postures, task-oriented, cognitive engagement, prevention of muscle shortening right from beginning, interdisciplinary teamwork, goal-oriented treatment, and patient engagement and involvement. These are the mechanisms of neuroplasticity I'm going to talk about, but various things like angiogenesis, spouting, unmasking of latest synapses causing synaptogenesis, and regeneration are the prime principle for the recovery. And these are the 3-step model for rehab schedule. You can see that how the patients are, because of availability of our new technology of MRI and fMRI, we could really see that how the improvement and nerve fibers do connect over a period of time. The neurological rehab program is aimed to help the patient through various methods. That means necessary skill to perform ADL, manage stress, anxiety, depression, receive training in bladder wall control, engage in support group to connect with their facing similar challenges. So group therapy, learn to use assistive devices. Many of us don't even know what are the assistive devices. Can be used even for a simple stroke, for the foot or for the hand or for the face. And acquire knowledge of safety measures to prevent the accident, because after the stroke, commonest cause of disability is fall and causing the fracture of the hip. And gain understanding and proficient management of home care. So these are the pathway of rehabilitation following injury. And I think we need to work on this, that how do we establish this sort of a program in our institute, where immediately when there is an injury, patient comes to the hospital, is been given the acute care either in ITU, neurosurgical, trauma center or stroke unit, and then he go into the hyperacute rehabilitation or the rehabilitation level 3 inpatient services, or he goes to specialized inpatient rehabilitation, which can be level 1, 2A or level 2, And then if he is supported discharge or community reintegration or the integrated care planning or specialized community rehabilitation. So we really need to create multiple channels. Government is creating various kind of program, 1,000 rupees into the XYZ, 3,000 rupees to the all women, the boys, the girl. But we need to really develop a program like this for each and every level of neuro rehabilitation because of the neuro disability. These are the various prevention of complication, because these are again very, very important. And what does a neurological rehabilitation program consist of? It helps in assistance with ADL, stress and depression management, pain management, speech therapy, assistive devices, bladder and bowel training, nutrition management, mobility activity, cognitive improvement, social and behavioral skill, patient and caregiver education and counseling, participation in community and support activity, vocational counseling. So you can see that neuro rehab is not one that you did a consultation and program. It is at various level with various kind of disability and involving the multiple people. So it's like a whole family being part of it. So these are the team. So you have patient, family, general practitioner, neuropsychologist, neurophysiatrist, occupational therapist, physio, psychologist, registered nurse, rehab specialist, social work, SLP, teacher and teacher's aide, vocational rehab specialist, work placement. So whosoever is required in that part has to be involved in this. The collaboration of these diverse specialty within a neurological rehab team ensure that comprehensive care that addresses the various facets of the patient condition maximizes the chance of successful rehabilitation outcome. So these are the assessment keys which are important. You need to look at cultural factor, belief of the of that particular society, gathering the baseline information, considering the history of past TBI, any post and pre-injury assessment, assessing pre-morbid condition, severity indication of initial injury, distinguish between current impairment, disability and handicap, informing about all the usual consequences of TBI or stroke, way to maximize the chance of success, ethically sound, valid and reliable method, assessment process, and prevent or caregiver as an active part to be included. This is admission care pathway, which also is similar to the pathway which I gave, which was robust, but this can be a little bit less, where you could have, go straight away into the water requirement at a level where you don't have that sort of a institute. So what are the phases of neuro rehab? So you have hyperacute rehab, that is within 24 hours, acute rehab, that is after 24 hours, subacute rehab in skilled nursing facilities, long-term care facility for nursing home and home with the home care services. These are the conditions we all know about, and this is the role of neurologist in neuro rehab. He should be the one who should be diagnosis and assessment. That is your forte. Development of treatment plan. So you need to plan a treatment that my stroke care patient first need to be mobilized. He need to work on leg function. I need to get him back into the walking, and then simultaneously work on the hand or assessing the speech or swallowing. And then monitor the progress weekly, that what program I have given is working or not working. Coordination of the care, management of comorbidity, so you train the family to prevent the complication, allowing them to pick up the early. So even if suppose there is a cough while drinking water, you tell them stop, come to us, go to the speech and swallowing therapist who can assess that he is coming early aspiration. And patient and family education, which is very important, because they are the one who could pick up the early complication, and preventing those complications could help us. Advocating for the patient need, research and evidence-based practice. The neurologist can guide the people, support for emotional well-being, transition of care at different level, that again has to be decided by neurologists, and refer to the specialist relevant, like bladder, bowel or hip, they have to be done, and participation in interdisciplinary team, getting all the team together, discussing and finalize the program is what is their need. So neurological rehabilitation plays a vital role in the recovery process, which is emphasizing the importance of collaborative approach. With the support of family, friend, community, and the medical team, patient can make significant stride in their healing journey and regain their ability to integrate journey. The primary object of a neuro rehab program is to enhance physical, emotional, social well-being, enabling patient to regain their highest level of function and independence. Through these programs, individuals often achieve the ability to live autonomously, leading to increased happiness and overall satisfaction in their life. WHO 23, Rehab 23 is the program which ensure, and India has signed the treaty, that we need to give rehab to each and every person in our country. Thank you very much. So, with that background of neuro rehab, I invite Arun Shivraman. If I can have slide of his introductory slide. The Arun is, a student of Dr. Lakshmi, and he is mentee for me at WFNR, and he has been especially interested in neuro rehab for past couple of years. He is very actively involved, and I request him to speak about the pulse in neuro rehabilitation. Arun.
Good morning, everyone present here. And I would like to, first of all, I would like to thank my teacher, Dr. Lakshmi Narasimhan sir, and my mentor, Dr. Nirmal Surya sir, in rehabilitation for providing me the opportunity. And I would also like to thank the organizers. So the neuro rehabilitation pearls, I just thought I will just discuss about 2 points or 3 points in each diseases about the importance of rehabilitation. So let's start with Parkinson's disease. So is there any rehabilitative measures to improve hypophonia in patients with Parkinson's? So here comes the Lee Silverman voice treatment loud. So Lee Silverman is the patient on whom the technique was introduced. It was developed by Dr. Lorai. She was a doctor. So as requested by the patient's families, she created it, and now it is being practiced wide over. So it is nothing but asking the patients to speak loud. So LSVT loud is built on 3 key strategies. So it increases the vocal loudness. So they have strategies to improve the loudness, and it have the mode of intensive dosage and high effort, and it also helps in recalibrating the sensory feedback. So after treatment, it is proven that it improves the vocal loudness, breath support, voice quality, intonation, and speech articulation. So these are some evidences to say that it has been published in Current Opinion Neurology about LSVT loud, that it helps improve the speech of the patient. Is there any structured protocol for physical rehabilitation in patients with Parkinson's? So LSVT loud has been expanded to LSVT big to improve the physical therapy. So what they say is Parkinson's patients' brain are wired to think small amplitude movements. So we help them to practice to make large movements. So it equals the normal movement. So that is the physiology behind this. So think big and walk big is the goal. So LSVT is an amplitude-based behavioral intervention in improving the speed and amplitude. So the main is to increase the amplitude of the movements. So it is an 1 month program of 1 hour sessions, 4 sessions per week for 4 weeks in a row with daily homework and carryover exercises. So the main theme of LSVT big is start big, hold big and end big. So this is an example of an exercise. It has exercises in supine, sitting, standing, walking. So we ask the patient to make and move the arm up, ask the patient to take the maximum effort to make big movements, go down big, make it overhead big, hold out loud and big and end big with the slap and the thigh. So this is an example of LSVT big. So there are many exercises, around 16 hours of sessions are there to complete a treatment course. So these are some evidences to prove the efficacy of LSVT big, and anyone can be certified. They have LSVT global website. We can get certification to be certified as an LSVT physician. And is there any ways to improve freezing of gait in Parkinson's? So here comes the cueing in Parkinson's. So cueing is an use of temporal or spatial stimulation to regulate spatial stimulus to regulate a movement. It is often delivered as an auditory or visual, auditory in the form of music, counting or metronome beats, visual cues in the form of laser pointers, adaptive glasses or lines marked on the floor. So the mechanism is, they say it compensates the degenerated rhythm within the basal ganglia. So auditory cueing improves cadence of the gait, velocity of the gait and stride length, and visual cueing improves the stride length. So these are some of the examples of visual cueing. So either a patient can have a wearable device in the form of band with laser red line. So it helps the patient to reach 1 meter of each step. And we can either use markers on the floor to make the patient to make it easy for the patient to navigate within their homes. So the visual stimuli has a spatial processing in the brain and improves the gait. Auditory stimulus and somatosensory stimulus has temporal processing to improve the gait. So these are some evidences. And in multiple sclerosis. So what are the ways to manage fatigue in MS? So either it could be a pharmacological management or non-pharmacological management are there, but recent evidences say the pharmacological drugs are not useful, they are not helpful in improving the fatigue. So they concluded that amantadine, modafinil and methylphenidate were not better than the placebo in improving fatigue. So what are the non-pharmacological measures? There are aerobic training and CBT, which everyone knows. So the main thing and the recent upcoming trend is the energy conservation management in fatigue. So what we do is, we teach people to identify and modify their activities to reduce the impact of fatigue in their daily life. So we just prioritize the tasks, focus on essential tasks, break your tasks into small manageable parts, simplify the tasks, establish a consistent daily routine, and provide proper scheduled rests. So these are the basic things for energy conservation technique. So this is the model schedule of energy conservation technique. So we sit with the patient, we discuss what is the need of the patient, we give them the chart, what to do and when to do, and we should keep on changing it as per the patient's needs. So what are the modalities to treat overactive bladder other than drugs? So this overactive bladder is one of the major issue in multiple sclerosis patient. Even I had a patient with overactive bladder. I just want to discuss about one technique which improved him significantly, which is posterior tibial nerve stimulation. So a tibial nerve is the mixed nerve that contains both sensory and motor fibers from L4 to S3. It originates from the same segments of the spinal cord and innervates the bladder from the pelvic, the innervation of the bladder and pelvic floor. So the mechanism is stimulation of tibial nerve with low frequency pulses at tolerable intensity can produce inhibition of the spinothalamic neurons in the spinal cord and in turn reduces the firing of pontine micturition center. So how to give posterior tibial nerve stimulation for a patient? So the duration of treatment is 6 weeks. The side of the leg, which side should be preferred? As per the studies, use left ankle because it has been shown that the right side of the brain is a predominant active area during micturition. Use 10 frequency hertz, 10 hertz frequency, and intensity is intensity of the stimulation where the patient has a tingling sensation on the sole of the foot with flexion of the big toe and a fanning of the other toes. The stimulation should not be painful. What should be the pulse duration? The pulse duration should be 200 microseconds. The stimulus duration should be 30 minutes. The frequency of treatment should be 3 times a week for at least 6 weeks course. So these are the evidences. So this is our patient. This was his pre-rehab when he was on catheter. He had difficulty in even standing and sitting. So we did physical therapy, we did aqua therapy, we did posterior tibial nerve stimulation for him, and this is him walking after 2 months. So this is a young guy, a 29-year-old male who had seen the fruits of rehabilitation. Now he is off to his work again. So this is how rehabilitation can change a patient's life. And moving on to stroke. Can you predict motor recovery after stroke? This is the most common question asked to every neurologist by the patient's attenders. And yes, it can be done by bedside. So to predict upper limb recovery, we have clinically we should score SAFE, that is shoulder abduction and finger extension, and NIHSS stroke scale. And we can assess the structural integrity, that is the sensory motor tract lesion load with the help of MRI. And we can assess the functional integrity with the help of transcranial magnetic stimulation. So the algorithm for predicting upper limb recovery is PrEP algorithm. The first step is after 3 days of stroke, you apply SAFE score, that is shoulder abduction and finger extension. So the maximum score is 10. So if the score is more than 5 at 3 days and the patient is less than 80 years of age, patient has excellent prognostic outcome. If the age is more than 80 years, if the SAFE score, the MRC grading of shoulder abduction and finger extension is more than 8, then the prognosis is excellent. If the age is more than 80 and the score is between 5 and 8, the prognosis is good. So if the patient age is more than 5, so score is less than 5, then we can go on to do a transcranial magnetic stimulation. If we can evoke a motor evoked potential with TMS at 4 to 7 days, the outcome is good. If MEP is not evoked and the NIHS is less than 7 at 3 days, and the outcome is limited. If NIHS is more than 7 at 3 days, the outcome is poor. So just with the SAFE score and NIHSS, we can assess the prognosis of the patient for upper limb recovery. When we are in a tertiary care center, we can assess the lesion load by assessing the fractional anisotropy asymmetry index of the internal capsule. So if the ratio is less than 15, the outcome is limited. If the ratio is more than 15, the outcome is poor. So this is how we assess the fractional anisotropy asymmetry index of the posterior limb of internal capsule. And how to predict lower limb recovery and walking in a patient with stroke. So the algorithm is twist algorithm. So we assess the trunk control test first. So what is trunk control test? So we ask the patient to roll to weak side. We ask the patient to roll to the strong side. Ask the patient to sit from lying position. Ask the patient to sit with feet off the floor for 30 seconds. So each test has 0, 12 and 25. So the maximum score is 100. If they are able to do the task completely, the score is 25. Able to do so with some help, the score is half, that is 12. And unable to do without assistance is 0. So the maximum score is 100. So you do trunk control test at the week 1. If the score is more than 40, the ability of the patient to walk at 6 weeks is around 95%. If the score is less than 40, and assess the patient's hip extension at the first week. If it is 3 or more than 3, the ability of the patient to walk at 12 weeks is around 90%. If the hip extension is less than 3 at first week, the patient is going to be dependent for quite some time. And how many repetitions of movement to be done in a day for functional reorganization? As per recent trials, they say around 400 repetitions of a single movement per day should be done for a brain reorganization. And how many gait repetitions or steps to be done in a day for a functional reorganization of the patient after a stroke? So as per study done in rats during treadmill training, they say more than 1000 gait repetitions or steps per day is needed for brain reorganization. So thank you. And I would like to take and I also thank the organizers for providing the opportunity. Thank you so much. Thank you.
Start.
What are the chances that you are going to be better in next 12 weeks or 6 weeks time? I think we should make a photograph and put these scales to be used by all neurologists easily. So we'll put up QR codes so they can scan and use it regularly in their clinic on the phone as and when required. Thank you very much. The
Sir,
next talk will be by...
With the permission of the chair, can I add one?
Yes, please.
Yes. See, regarding the tibial stimulation, sir, for the overactive bladder and incontinence, we have very good experience. What we have done is not even put the needle. We do a surface. We attach a surface EMG on the tibialis anterior and then do a stimulation similar to that non-invasive, and it has produced very good results, sir. We have. In fact, one of my PG, Professor
Jogo
Dr.
is the
Noel,
commercial company which provides these services, JOGO, and they charge about 5,000 rupees.
Joho is a biofeedback one.
Yeah, but that also is
it's for
very simple
incontinence.
for the bladder function also.
This one, this is using the method which he had shown, the posterior tibial nerve stimulation, where instead of the needle EMG, you can also use a surface EMG, which gives equally good results. One of my PG's dissertation, Dr. Noel's dissertation was that, and it improves continence very well.
So that Jogo can be worked for both stool as well as urinary incontinence. So for your knowledge, if anybody has some patient and need any help, they can always connect me or Arun or Guhan. So move on to the next talk. Can I have the introductory slide of Hitav Someshwar? He is an assistant professor, he is a neurophysiotherapist, assistant professor, physiotherapy department at Nair Hospital, where I started the first neuro rehab OPD in 2000 in India. He is now leading there, and he's been member of various organizations like WRA as well as founder member of IFNR. So he's going to speak about assessing and planning neuro rehab case-based approach. So from the therapist point of view for a neurologist. Please go ahead with them.
All right. So we'll be discussing about how do we plan neurorehabilitation or how do we assess a patient. See, I'm no one to tell a neurologist on how to assess a patient, but there is certain differences in how a rehab professional like me, like a physiotherapist, assesses a patient and how a neurologist assesses. So in the morning yesterday when we had the session, when he was only talking in Hindi, more of us did not understand this. So what happens is when a neurologist assesses and he writes down things on a piece of paper and sends it to us, it gets difficult for us also to understand. If I'm talking in English now, I start talking in Gujarati, there is not going to be a lot of information that can be transferred. So the World Health Organization has come out with the ICF-based rehabilitation assessment, which I'll be discussing in a few moments from now, which makes a uniform background or a uniform language between neurorehabilitation professionals of a multidisciplinary team to communicate. Okay? So now what is the importance of assessment is it identifies the specific deficits, it establishes a baseline, it facilitates personalized treatment plans. One size does not fit all in neurorehabilitation. Every stroke patient is different, every TBI patient is different. It aids in setting realistic goals and it prevents complication. Now, why is it important to have tailored treatment for specific deficits? Because see, again, I want to repeat this, that one size does not fit all. Like the same way with medicine also, the same medicine is going to act differently on me, is going to act differently on someone else. So that is why it is necessary, because it will help in optimizing recovery, enhancing the engagement, improves the functional independence that is there. It addresses the diverse needs. For me, if I'm staying on the second floor in a rural setup and I have to climb stairs to go on top, but someone who's staying in a metropolitan city who has a lift, so I don't need to I don't need to treat him or manage him in stair climbing. But for the rural patient, it is the most important. So that is how the treatment changes. And it promotes long-term quality of life in our patients. Now, coming to what is ICD and what is ICF, most of the neurologists in our country are using the international classification of disease because this helps in the discharge planning, this helps in the insurance papers as well. This was first developed by the WHO in 1893 and is currently in its 11th revision as of 2022, and it's providing a global standard for diagnosing and tracking diseases. This is good to diagnose or label a patient. But as we are again and again saying, every patient is not the same. So the World Health Organization in 2001 came out with ICF, that is the International Classification of Functioning Disability and Health, which focuses more on measuring health as a function and not as a disability. So you diagnose the patient based on an ICD, this thing, but then functionally evaluate and treat a patient. So the challenges that are there for using ICD and ICF is the complexity of implementing these frameworks in diverse healthcare settings and ensuring consistent interpretation across different regions and specialities. What happens over here is this is good for an European or an American neurologist who's only seeing 4 or 5 patients. With Dr. Surya seeing 50 patients a day, it is practically impossible for him to use the ICF. But WHO has made even more better things, but we are not yet perfect, but we are getting there. So this is a classification difference between the ICD and an ICF. The perspective of ICD is disease oriented and the perspective of ICF is functional oriented. There is a biopsychosocial model that is used, and both can be used for discharge planning, both can be used for insurance planning. And then the categories are based on disease, but here they are based on the body structures, functions, the activity limitation and participation restriction. And they even take into consideration in ICF is the environmental factors and the personal factors. Someone staying in America, someone staying in India is going to be different. The same way someone staying in rural India and the metropolitan India is different. Someone's personal factors also do play important roles in this. We'll just check in the next few slides. Functioning as a core. In 2001, the WHO changed its definition and said that not only talking about disability and this going from mortality and morbidity, they went on to functioning. How well can a stroke patient function? So functioning is a central dimension in person's experience or likely to experience disability. ICF has established a patient-oriented functioning profile that we have been seeing. And moreover, functioning represents not only an outcome, but also the starting point of clinical assessment, intervention management, the post-intervention evaluation and quality management. So, the integration of the biopsychosocial model of functioning, disability and health. So you see the health condition is there, that your ICD is not wrong. I'm not trying to say, because both are by the WHO. If they wanted to remove ICD when they introduced ICF, that would have happened 21 years back. But I'm not debating on this. ICD has to be used till the patient is diagnosed and has been critically taken care of in his critical stage, and now he is vitally stable, and then we can come in for assessing the body functions and structures, the activity limitation, the participation restriction, and the environmental factors and the personal factors. One important point over here to know is, if you see the arrows, they are bidirectional, they are not unidirectional. So everything is interdependent on everyone. So that is why even your health condition is dependent or interdependent based on your activity limitation and your participation. Coming to what is happening in the ICF. So you all know the ICD codes. The ICF has something called as a structure. So first they have a chapter level, which is denoted by B. B is for the body structure and function, which has a code that is 2. So that is the chapter level, which says that it is the sensory function and pain. Now coming to the second level, now sensory function and pain may say only sensation of pain if I want to take, my code will become B280. Then there is a third level, if it is a pain in the body part, or if it is a generalized pain, or if it is a psychological pain, there are different level codes. And pain in the back, they are exactly telling you, so that the code is B28013. So what happens over here is, the patient is given this code and the ICF is given, you just enter this code and you will come to know what is wrong with your patient. So ITF categories are arranged in stem, branch, leaf structures within each component, in which the more detailed level categories say the same attributes as the more broader level categories. And then there is something called as qualifiers. So we always say, that how severe is the disease or how severe is that impairment. So they have given a qualifier saying from 0 to 9, where 0 is no problem, 1 is mild problem, 2 is moderate problem, 3 is severe problem, 4 is complete problem, 8 is not specified, and 9 is not applicable for our patient. So the World Health Organization proposes that the categories in the components of body structure, function, activity and participation be quantified using the same generic scale. So what happens, we have n number of scales. A lot of our students in the PG, when they have to present their case, they want to take outcome measures in our physiotherapy field or in other rehabilitation field. They don't understand which rehabilitation scale to take, which outcome measure to take. ICF is an outcome measure itself. So you don't need to go depend on to another outcome measure. These qualifiers help you in finding those things out. Now coming to the environmental factors and the personal factors, here it is based on a negative and a positive scale. They are based on barriers and facilitators. Environmental factors is everything that is happening in the surrounding. Here if you go to see if there was a disabled person who would come, he wouldn't be able to climb onto the stairs if there was no ramp over here. So that would have been a barrier for him to come on stage and speak. So again, the barrier has to be either no barrier, mild barrier, moderate, severe, or a complete barrier. The same way, if there was a ramp, that would have been a facilitator for them. We have a lift, that is a facilitator for us. So accordingly, we have to keep noting these things down. So now coming on to the rehab cycle. What happens at a rehab cycle? It's a continuous cycle. It's a continuous this thing, and this is given by the World Health Organization, saying that first you need to assess, then you need to assign. This is the role of a neurologist, because majority of the time the patient is your patient, you are the main consultant, and then you are the team leader of the multidisciplinary team, and at times PMRs are also the multidisciplinary team leaders. So assessment and assignment, what more body function or what structural function which has to be treated has to be assigned to a particular therapy. Or to a therapist. So a lot of us don't know what an occupational therapy does, a lot of us don't know what a physiotherapist does, or a speech and swallow therapist does, or a psychologist does. So ICF helps you do that. And then comes is the intervention. So ICF has come out with an international classification of health interventions also. For every body function, they have a list of 10 interventions which can be given, and they are from a rating of 1 to 10, where 1 means the level is the best and 10 means the level is not good. So you can start checking for the evidence-based practice based on that only. And as I said, that ICF can be used for evaluating as well. So that is when you can evaluate, and once you evaluate, you have to go back to assessing again. So it's a whole rehab cycle. You have to assess. Assignment is where we as neurologists or we as neuro rehab professionals are lacking, because we are overpowering, we are doing something what is not our forte. And that is where there are ego clashes, there are fights that are happening, and that is when we are losing the best, we are not able to give the best quality of treatment to our patients. So I'm going to discuss one case which had come to us. It's Mr. D, a 41-year-old farmer who lived and worked in a rural area of northern Maharashtra from where I come. A fall resulted in a spinal cord injury that had a drastic impact on his life. He suddenly fell and roughly tumbled a short distance down an incline in his mountainous hilly area. The fall resulted in immediate paralysis with no sensitivity in his extremities. That is both the upper and the lower extremities. So his family and he lived in a small house which was elevated on bamboo sticks to accommodate rising water levels. A pit toilet was situated about 20 meters away. As this case study will show, the architectural setup of Mr. D's housing posed accessibility implications for his community reintegration planning. What happens over here is that is why we are saying ICD does not take into consideration the environmental factors. He stays in a slate house which is elevated to take into consideration his rising water levels. That means there are steps. He's supposed to be on the wheelchair. Is it possible for him to go on top? Yeah, the washroom is a pit toilet. It's an Indian style toilet. Imagine a quadriplegic patient to use that, even if you teach him all the maneuvers for bowel and bladder management, to use a pit style toilet which is 20 meters away from his house is going to be difficult as well. So, diagnosed with a traumatic disc herniation at C5, C6 and a spinal cord contusion at C3, C4 level. The Asia impairment scale was grade C. Spinal surgery was performed at 5th and 6th vertebrae were plated, and after the surgery was fitted with a soft collar. At admission in the early post-acute rehabilitation unit, a 6-week rehab cycle was planned. Alright, so the structural and functional limitations that were seen were decreased in joint mobility in his ankles, severe spasticity in his lower extremities, severely reduced muscle power in his legs, arms and trunk, and as a result there was reduced involuntary movement reactions. Touch functions were impaired in the area below his level of injury and unable to control his urination and defecation at all. So then we went on to the ICF. This is the ICF book that is there. We went to the book and then we found out what we need to do. So we spoke to a patient, we heard what he says, like Dr. Sudhir Shah also said, instead of talking, be a good listener. So we did that and we understood what he wanted. So he said that it is not working like normal. That were his words that he said. In Marathi he said, "Nai chalat barabar." This is not how it has to function. And he indicated a lack of control over his hands and legs, struggling with spasticity that increased after exercise. Mr. D stated that the spasticity in his hands made grasping objects difficult and activities like washing himself and walking were also negatively impacted. So what happens over here is we are seeing the function that is impaired. We all know there is spasticity. So the previous slide spoke about whatever a neurologist or a physiotherapist assessed. But here, my patient is telling me what are the functions that are impaired or what are the activities that he cannot do, which what is impaired, and that is what ICF allows us to do. So the contextual factors, again, based on his history and this thing, we came to know that the house was built on stilts and was surrounded by uneven ground, and the pit toilet was located 20 minutes. He's a farmer with limited financial resources, lack of assistive devices are available, and the physical demands of his job as a farmer. Can a spinal cord injury patient go back? So that is a barrier that is present for him. But the facilitators were also there. There was a supportive wife and family, educated doctor, and he had access to healthcare. And access to free healthcare is what was more important for him. So now assessment. We did the spinal cord injury measure, which was 2 weeks following his trauma after his surgery when he came for rehabilitation, and his score was 21 at that time. But the most important thing is this ICF assessment sheet. So if we go and see, so here, this is what is the patient's perspective. And here is what the health perspective is. We always say, Dr. Surya also kept saying that patient has to be kept at the center. Patient is God, patient is the leader. So always place what he thinks is a problem. And then you assess it And certain times, you know what happens is, when we assess, we come to know certain signs and symptoms which the patient does not tell in his history. And that is what comes second. And then there is the activity and the participation restriction. Again, first, what the patient could not do, and second is what the patient could do. And then there are the environmental factors and the personal factors that are present. And this is easily available. It's just a checklist that you need to fill, and the computer will give you this table. And now this is the functioning profile of the patient that was done based on the ICF, and you can see the qualifiers over there, 1, 2, 0, 2, 2. And the cycle goal that was there is to prevent secondary complication, independence in mobility, and independence in self-care. These were our 3 cycle goals that we did. And ICF makes this as your functioning profile, which is easily available on the WHO website, free for use. And it tells you what are the categories that are available, what are the goal that is there, if you have to correlate that to your goal. And the goal value is based on GAS, that is the goal attainment score, which is a -2 to a +2 score, where we come to know whether we had set SMART goals or no. So this is what we did for our patient. This is a functioning profile, easily available and very easy to do. It's self-explanatory, but it goes a long way in protecting our patients and covering insurance as well at certain times. Then we check for the facilitators and barriers that we discussed, and what are the goals, what were the goal attainments that were present. And now this is last 2 minutes. This is the most important intervention table that we kept talking about. So here it is talking about the intervention. It is talking about which professional has been assigned to take care of that impairment or that functional limitation. So this makes it very clear whose job is what. So then it gets easier. So the neurologist can form this. The doctor can be a neurologist, a PMR, a plain MBBS, or can be a pediatrician depending on what is available at your center. Then we have a nurse, we have a physiotherapist, occupational therapist, and social worker. And then what goals are there and what are the interventions? These interventions have also been taken from ICHI, that is International Classification of Health Intervention, and this table has been made for easy communication. This is there in our patient's file. So anyone who opens the file can directly see what is there and what is not there. Sorry. So this is also an intervention table, extended version. And then the outcome, if you see how the outcome was after 2 week, 3 week, and 6 week, there was a change from 21, 68, and 72. Our patient was able to walk. Our patient was able to walk with the help of crutches and could use an Indian style commode with certain modifications that were present. And as I said, it is easy. ICF has developed course sets for various conditions. It's given on the website called as icfcoursets.org. Everyone can refer to them, and it is given very easily, and it makes the functioning profile for you, the assessment sheet for you, as well as your intervention table. And under the able guidance of Dr. Nirmal Surya, we have formed something called as KAR. In Hindi means to do, and it is knowledge for all repositories. And here we have been giving you outcome measures easily available under one platform for all the ICF domains. So if you want to assess balance, all the outcome measures are given. We have even given you their reliability, their validity. So everyone is welcome to please visit our website ifnr.org. And this has been one platform for neurorehabilitation for the outcome measures that need to be used. And with this, I would like to conclude saying that neurorehabilitation is a holistic, patient-centered approach, and through proper assessment and assignment, we can come and get better results, and evidence-based planning is the need of the hour. Thank you.
Thank you, Hitav, for giving an elaborate concept on ICF-based model for the assessment and care for the patient with neurodisability. I think in future more and more of ICF will be used And it is very important for neurologists to be aware about how our rehab specialists are going to put the code on the ICF so that we know that how the progress has been done. We move forward. I think you keep your question at the end of the session for all of them. We move forward to the next talk by Preeti Sethi. Can I have her introduction? She is an assistant professor at Department of Audiology and Speech Language Pathology, Kasturba Medical College, Mangalore. She specializes in speech language pathology, and she has been also working on the neuromusic therapy along with our Professor Michael Todd, who is like a father of the neuromusical therapy, and she worked for the Speech and Swallowing Foundation. So she's going to talk about the assessing swallowing in neuro rehab. Over to you, Preeti.
Thank you, sir. Good morning, everyone. At the outset, I would like to thank the organizers and Dr. Surya for the opportunity. I would be discussing the assessment of swallowing and its implications in neurorehabilitation. Swallowing is a complex mechanism because of its anatomical location. The pharynx and larynx that's there is common for respiration, swallowing, and phonation. So, in addition to the muscles, cranial nerve, and functioning of central nervous system and peripheral nervous system, cognitive control is also important for swallowing. So, swallowing is not only nutritive, it is also important for protecting the lower airways. So if you see the phases of swallow, we have oral phase, which is voluntary. It is controlled by central cortex and limbic lobe. We have pharyngeal phase, which is involuntary, which is coordinated by brainstem swallowing center. And we have esophageal phase, which is involuntary and reflexive. This is again controlled by brainstem swallowing center. Swallowing is sensory motor phenomenon which is meticulously timed, and evidences have shown that both peripheral and central nervous system is important for controlling the swallow mechanism. So again, as I said, it is multidimensional in nature. So the receptor in the oral structure, larynx, pharynx and esophagus has the receptors which is sensitive to it can be thermal receptor, mechanical receptor, chemical receptors or pain receptors which carry the information to the cerebral cortex through cranial nerves, and swallowing output is initiated. Okay, so again a lot of organization and motor activity is important. So important cranial structure nerves that is important is olfactory, trigeminal, facial, glossopharyngeal, vagus and hypoglossal nerve. So along with these cranial nerves and central motor control or central nervous system control, hunger and thirst is also important. So the information from the periphery about hunger or fullness is sent to the hypothalamus and it reaches the cortex and limbic system. In addition to that, taste and smell is also important because the smell reaches the piriform cortex and amygdala, and then it reaches the orbitofrontal cortex or insula, wherein the taste is reaching the nucleus tractus solitarius, then to thalamus and then to OFC and insula. When taste and smell both are in combination, lateral anterior part of orbitofrontal cortex is stimulated. So if you look at the different conditions of neurological disorders, definitely there will be some percentage of swallowing difficulties that can be seen. The upper limit is up to 90% of the time. So we'll have to assess appropriately and initiate the intervention as quickly as possible. So we'll have to have a valid, authentic tool or assessment procedures to evaluate the current condition of the patient, which is sufficient enough and reliable enough to initiate the intervention. So there's no global consensus on how the assessment has to begin. but selecting the right tool is very, very important. So there can be a diagnosis of dysphagia with known and unknown diagnosis. Majority of the time, whenever it is referred, we have a multidisciplinary team who's going to refer to us. If it is based on esophageal dysfunction, a gastroenterologist looks at it. If there is a oropharyngeal related dysphagia, if it is structural deficits, an ENT looks at the intervention and assessment. If it is functioning, I think all the interdisciplinary team comes into picture, where it is referred to a speech language pathologist who assesses the clinical swallow features of the patients. We further investigate on video endoscopic swallow study or fluoroscopic swallow study, then plan the management to reduce the risk or to optimize the hydration and nutrition of the patient by giving them non-oral feeds, which can be by NG tube or PEG tube, or we can modify the consistencies of the bolus which is safe for the patient. We modify the posture, or we also give compensatory strategies, that is important, and also supplements and dietary advices, which is important for the patient. Whenever we assess, we always have to think that's the baseline that we are taking of a patient. Whatever assessment that we do, we have to take it forward for the intervention. We always have to take a detailed history, look at what are the symptoms and what is the lesion and what are the exhibiting feature of the patient. So there can be a screening test, there can be a diagnostic test, or additional objective tests in addition to whatever assessment we have done. But all this depends on which setting are you evaluating them. Is it an acute care? Are you looking at them in an outpatient setting, or have they come for an intervention? So the most common screening test that is used is E10, Yale Swallows protocol. The diagnostic test can be clinical bedside evaluation or clinical evaluation, MASA, cough reflex test. The objective test that can be included here in the assessment is fibro-optic endoscopic evaluation of swallowing, video fluoroscopic swallow study, high resolution manometry, or surface EMG. Again, whenever we are assessing, we look at which stage or which phase of swallow is affected. To begin the assessment, it can be screening, it can be diagnostic or objective evaluation. We always have to have something which is a prerequisite. We'll have to test the patient in both liquid and food test. We have to check the bolus, what is the quantity that is feasible or that is safe for the patient, or what is the viscosity that is safe for the patient, if it is liquid or what food that we are choosing. Again, whenever we are choosing these, we have to have a standard measure, that is IDSI, International Dysphagia Diet Standardization, which has been initiated in India also. So following the food preparation or the ingredient that you want to assess, you have to do a dry swallow evaluation, non-swallow evaluation, and wet swallow evaluation of liquid and food, which gives you an idea of the cognitive status of the patient, which phases of swallow is affected, what are the muscles that would be affected, what is the bolus type that is feasible for the patient, what positioning or what are the compensatory strategies that is safe for the patient, and is the patient dependent for the feeding. So again, bringing in the principles of dysphagia intervention, we have to prevent the complications, we have to create a safe and efficient swallowing setting, and also improve or compensate the problems that we see, and also treat the symptoms that the patient is exhibiting. So I'm not going into details of each and every disorder, but if you see the case illustration, it's a patient of 62 years old who has a left MCA infarct, who was first initial diagnosis was done by bedside evaluation. He was on NG tube for 19 days, and if you see the cognitive status, there is reduced alertness, and also you get to know what is the oral muscular structure or strength that is there. If you see, there is reduced lip seal, there is poor hygiene. Again, occasional swallow for thick liquids is there, and fair saliva management is there, and the patient was fully dependent as he was on NG tube and reduced alertness. So when we did the basic bedside evaluation, we always have to start the intervention where we worked on orientation and stimulation. We also started the oral feeds. Again, we have to identify what is the level at which we are giving the volume or viscosity that is chosen. We started with 1 ml and then started the muscle strengthening and continued the feeds by NG tube. So after 15 days, when we did a fees evaluation and detailed clinical evaluation when the patient was okay, so we diagnosed the patient again having oropharyngeal dysphagia, but again because of pooling that is there in the valvula or delayed swallow reflex that's there, again that correlates with the reduced alertness. Again, even though it is because of reduced alertness or anything, we also have a lesion. The patient is not showing major signs of aspiration, but still there is a lot of chances that the patient can aspirate, and there is a spillage and there also is a pooling in the valvula. So the recommendation here is cognitive linguistic intervention, because we have to work on the cognitive functioning also, along with trying different bolus and strengthening the swallowing musculature, that is important, and again re-evaluate the patient so that we can continue in the intervention. So again, the other 3 cases, if you see, they are patients of lateral medullary syndrome. Case 2 is on RT since 30 days, and there is a right vocal cord palsy with in a full abduction position. Throat clearing is there, nasal regurgitation, aspiration of liquid and food is there, and a difficulty to swallow saliva is a thing. If you see the intervention that is done, irrespective of compensatory strategies, thermal stimulation or sensory stimulation, the patient was not responding. So the initial first recommendation is to give the PEG. Why? Because the patient is already on RT for 30 days. So we also have to look at the what is the immediate recommendation that we do, and then start with the intervention. Eventually this patient was the intervention for this patient was injecting the botulinum toxin, because with lot of interventions in terms of behavioral or compensatory strategies, it didn't work. So if you see the case 3 and case 4, both are on RTs for less than 15 days, and their vocal fold has palsy, but in paramedian position or abduction position, which is not full abduction position. There is aspiration of liquids only for case 3, and throat clearing and aspiration of both liquid and food for the case 4. There was a lot of improvement after working on oral muscular stimulation, strengthening vocal fold closure and elevation strategies that are there for both the patients. So for patient case 3, we removed the NG tube because the patient was able to safely swallow everything, because if you see, they had the patient had aspiration only for liquids. So for case 4, we progressed in the bolus type that was there, so we started working on thin liquids. So this is how you can look at assessment, converting it into intervention. So if you see the patient, there is a pooling in the pharyngeal space and also valvula, and after the intervention, again we have to look at which strategy is useful for the patient. Here, head rotation with supraglottic swallow, it's a maneuver that is used. We might have to look at combinations, which was successful in rehabilitation, or safe swallow, which was elicited for this patient. So if you see other patient, it's a left pontine stroke. Again, there is pooling in the valvula and pharyngeal space or laryngeal vestibule, and poor saliva management was there. So oral muscular strengthening, isometric and isotonic exercises, maneuvers. If you look at stimulation using different taste or citrus, if you use, it is a sensory stimulation that is going to be there. It can initiate the swallow reflex quickly. You can use different bolus which is thicker. You might have to go from thicker to thin so that chances of aspirations are less, and then you have to increase the number of trial that is there. And again, if a patient is not cooperative, you might have to choose the time of example, if their NG tube feed is at 1 o'clock, you try at 12:45, so there is a natural response that is there. So you'll have to choose the time, you'll have to choose the stimulus, that is in terms of sensory stimulus, the bolus that is there, the volume that is there, or any compensatory strategies that is going to be useful for the patient, or combination of two strategies can be useful. And then you have to look how the patient is responding. You'll also have to look how much trials the patient is able to take, and then look at the same feeds or oral feeds for consecutive 3 days, and then remove the NG tube. So that's the process that you will have to look at. So this is a patient who had pooling. If you see now, the patient is taking the thin liquid, which is safe. So again, a patient of GBS, nothing by mouth was preferred at the initial evaluation. So on fees evaluation, what we found is poor secretion management, pooling of saliva in the laryngeal vestibule, micro aspirations of these saliva was there. The arytenoids that are there is floppy, and the adduction of vocal fold movements are weaker. So immediate peg insertion, because there's a lot, aspiration is happening because of the NG tube that is there. So sometimes pooling of saliva is there, you can use the compensatory strategies or behavioral management, anything that's there. But if there is aspiration, and if it is happening because of the NG tube, you might have to choose the other alternate method that can be used. So I think with this, I would like to highlight there has to be multidisciplinary approach between the consultants and the referral at the right time. Initiate from the acute stage or from the inpatient, and then bring them to the outpatient setting where you can help them even more. Probably choose a test which can screen, and it can identify one condition where you can start treating them, eventually evaluate other phases or other things that is there, and have a holistic approach so that you can work with the patient comprehensively. Thank you.
Thank you, Priti, for giving us case-based approach on the swallowing assessment. I must say that as a neurologist, we fail in doing the assessment of swallowing on day one of the stroke patient. We happily introduce the Ryle's tube, and we only call the swallowing therapist when we have to remove the Ryle's tube or patient is going. In fact, one of my DM residents took this thesis of swallowing assessment on day one, and 72% of patients with stroke had swallowing affected, which became 38% on day 3 when the patient was out of the ICU. And at the time of discharge, the 28% patient of posterior stroke had persistent Ryle's tube and dysphagia, while anterior stroke improves to the only 12% patient has. So we should make it a habit of getting this assessment not on day 1, and at least day or 2 or 3 of all patients with the stroke who requires the NG tube, or who before we start the swallowing. Thank you very much for this topic. I think my idea is to sensitize the neurologist to, get into the daily routine practice and avoid the complications which can easily, if you prevent a aspiration pneumonia in a stroke patient, you can reduce his 5 days stay in the hospital by just proper evaluation. We move on to the last talk by Guhan. He is convener of the Neuro Rehab subsection of Indian Academy of Neurology. I think one of those who has formal fellowship in Neuro Rehab from Singapore. So there are very few people in this country who are qualified neuro rehab fellow, and he is one of them, and I must congratulate him that he has patience to go to Singapore and work in the neuro rehab department for 1 year. I think his experience would be really great help and inspirational to many other young neurologists. He has learned a lot of new technique, and it also highlights that how newer intervention has played a role in neurology practice. We never had looked at beside consulting. Now young people are going into the stroke intervention, but there is beyond stroke, which can be much more easy. You don't have to depend, and less risky as compared to, it's equally paying. So he's going to talk to us about role of ultrasound in neurorehabilitation. Thank you.
Thank you for the kind introduction, sir. It is indeed a prestigious platform for me because I stand before my Guruji and my mentor, and I sincerely thank my Guru Dr. Lakshmi Narasimhan sir and my mentor Dr. Nirmal Surya sir. One student cannot ask for more of having such caliber Guruji and mentorship in life. I thank the Almighty God and I seek the blessings of my Guru and my mentor before I proceed with this talk. Ultrasound and neurology and neurorehabilitation. Before that, as a neurologist, when I started career, and any neurologist would be inspired to get into interventional neurology, and rightly so, I was in that path. But then when I started my practice, I realized that neurorehabilitation is the only subspecialization that brings you more close to neurology rather than any other specialization. You take interventional neurology, you tend to go away from neurology, practice more interventions, forget general neurology. Epilepsy, focus more on planning the surgeries, go away from the general neurology. But neurorehabilitation, you rehabilitate stroke patients, you rehabilitate Parkinson's patients, and you rehabilitate every other neurological disorder. So the way I looked at neurorehabilitation initially was that neurology, when a patient completely loses all his juice to the disease, neurology fills up to a certain level. But we say that, sorry, we don't have any more interventions, we leave it to the hands of the God for the rest of improvement, or go to rehabilitation and you will get the rest of improvement. So I realized that rehabilitation is the one that fills up the juice and gets the patient back on track and gets him back to life. So it uses the energy from all 5 elements. If you look at it, it uses energy from fire, water, air, earth, and space, and that conspires together to get the patient back on track. So that's all about neurorehabilitation, and that is done in an evidence-based manner. And in fact, when Dr. Sudhirsha sir was mentioning yesterday in one of the 10 commandments, more than the amount of energy and time you invest in the patient, it is the outcome that you should bring to the patient for a better career. And rightly so, he was mentioning it that neurorehabilitation should be incorporated into the curriculum of neurology, and rightly in that direction, Dr. Nirmal Surya sir is taking up this neurorehabilitation in a serious way to get to every single neurologist across the country. So now getting back to my topic, that is neurosonology. So what we are going to focus as a neurologist, when we hear the word neurosonology, we look at TCD and we look at the carotids. But what lies beyond in neurosonology? Whenever we do neurology, we look at history, clinical examination, we come to the conclusion of, is there a lesion, what is the lesion, and where is the lesion? We proceed ahead with investigation. If it is going to be a central nervous system, we have beautiful images from the MRI and the CT angiography reconstructions. But what happens when you come to the peripheral nervous system? Diffusion tensor imaging is good enough, but is it widely available, or can it be interpreted so easily like we do it for the central nervous system? So that's where the lacunae was until the arrival of this man, the investigating human, that is the Brahmastra. So the Brahmastra for a neurologist is this ultrasound probe. So actually when I was in my MBBS days, I used to have this fantasy ideas that if I could have something that I could sit directly within the patient to find what the disease is rather than assuming things in my mind, and that would be the best gift that I could have. And it is this Brahmastra that's actually helping us to do the things. You can actually rightly visualize what's under the skin, into the body. Low frequencies, high frequencies, wherever you want to get, you arrive at that place. and you visualize what's happening in there. But what happens the first time I would put a probe on myself, I see grays, whites, and blacks. That really disappoints me. But when you start to appreciate the beauty in the curves and the shades, that's where ultrasound starts to make more sense, and you start to enjoy the images. And can I please know what is the current level of exposure to ultrasound beyond the carotids and the transcranial Doppler in the audience? Who is ultrasound naive? Can you please raise your hands? Okay, has used ultrasound machine before for carotids and Doppler? Scanned one nerve and one muscle compartment? Scanned all the nerves and muscles in the body? That's great. So looking at the diagnostics aspects, because neuro rehab is a blend from neurology all the way till the patient improves. So we start from diagnostics and goes into the therapeutics. And rightly so, for a neurologist, we scan the nerves. And a nerve would have a honeycombing appearance. And this talk is going to be an overview to sensitize the importance of ultrasound in neurology and neurorehabilitation beyond the carotids and the ultrasound and neurorehabilitation. And this honeycombing structure wherever we see is the nerve. Okay, but then we keep seeing it again and again, and the next time we see an image, we can easily appreciate a nerve. On the lighter note, what is the structure here? Can anyone tell me? This is to check if everyone is awake or sleeping. What is the structure here? I hear it. Eiffel Tower. Where is it located? Paris. That's nice. What is this? This is again Eiffel Tower, but where is this? Las Vegas. So how did we come to the conclusion? For the first, we saw a lake in front. For the second, we saw Caesar's palace behind it. And now we came to the conclusion that it's Las Vegas. And that's how, when you scan the nerve, you look at the surroundings and the landmarks and not only the nerve. And here there is an Eiffel Tower again, but this is in China, a theme park where you can see all 7 wonders together. So when I look at the nerve, the company that it keeps, if I see 3 hills, then it is an ulnar nerve, at the ulnar groove. If I see a rabbit structure, I'm sure that team A wouldn't forget this. This was their quiz question yesterday. If I see a rabbit and I draw ears to it, the ears will encircle the superficial peroneal nerve. And this is how every single nerve in the body, based on its surrounding neighbors, can be interpreted as to what nerve is it. Now, what is the common pathology that we see with nerve ultrasound is an entrapment neuropathy. And this is the commonest nerve that's scanned across the globe, and that's the median nerve. So you can see all the tendons underneath the median nerve. And don't think this is an abnormal one, because this is my own nerve, and this is a normal median nerve. And measuring the cross-sectional areas, these are few standardized institutional protocols. This is one from the National University Hospital, Singapore, where they use for the various cross-sectional areas for the nerve ultrasound at fixed points. And we can use it for inflammatory neuropathies. You know, CIDP, we see the latency being prolonged. We actually don't see the nerve. We assume the nerve to be inflamed. But the first time I put a probe on the CIDP patient, and I scanned through the nerves, it was like bundle of grapes. The beauty of it was a sight to behold. And without any knowledge, I just out of that moment, I said, wow, it looks so beautiful. And the patient beside me was that, look, I'm quadriparetic and you are saying, wow, what's wrong with you? So that's the beauty, that these ultrasound can actually make you visualize these demyelinating nerves. And in those situations where you have the doubt, is it really demyelinating? You put on the probe, you visualize the inflamed nerves. And in fact, this is an ABUS criteria as a part of the EFNS and PNS. If you have a possible and a probable, then you do the nerve ultrasound. If it scores more than or equal to 2, then it is more likely to be a CIDP. The next place where it's useful is the nerve tumor. Many a times you think there is a nerve palsy, your axonal changes in the nerve, and then you look for the MRI, but the MRI shows you the indirect evidence. What it compresses the nerve and not the nerve per se. You can make out the nerve, but not always. And then, but when you put the probe, you might actually look the nerve per se in the nerve ultrasound, and you can make out tumors. So here is a schwannoma, and we make out these structures when we scan the length of the nerve, and not just one point. that helps us in differentiating, is it a schwannoma, is it a fusiform inflammatory neuropathy, or is it a inflammatory polyradicular neuropathy. Now coming more close to neuro rehab, that's the assessing the muscle, can actually assess the normal muscle, and you can see the dystrophic muscle with lost architecture on the right side. And for the assessment of the muscle, we just eyeball, we see that there is some hyperechogenicity, but now we are coming to the era of evidence where we need to quantify everything that we do. So we started with a semi-quantitative measure. The initial HECMAT grading is for dystrophic muscle, where we see if we are able to see the bone underneath. The more the bone disappears, the higher the grade we are at. And then coming to spasticity, this was extrapolated from the HECMAT grading for the dystrophic muscle. It's a modified HECMAT grading where if the hyperintensities occupy less than 10%, 10% to 50%, 50% to 90%, and more than 90%, and that's grade 1, 2, 3, 4. Any photograph enthusiasts here? Because many of you hold cameras, and the same pictogram that we use in photography, we can use it for a muscle and get the standard deviation out of that histogram. And if it is more than +2 standard deviation, that denotes the muscle is spastic, because many a times we are confused if this muscle is spastic. For example, if you have this biceps brachii, the one on the left is hyperintense. So we know that, okay, this is spastic muscle through ultrasound. But on the right side, is it spastic? Is it hyperintense enough? How many of you say that the right muscle is spastic? Can you please raise your hands? Not spastic? Anyone raising the hand? So this is the confusion it creates. You apply the histogram and you get the standard deviation. So the mean echogenicity for the one on the right side is 2.61. And this again is beyond 2 standard deviation, and that helps us identify that this is a spastic muscle, and that needs to be taken care of in the rehabilitation. And then we have shear wave elastography that's used for the liver to assess the stiffness of the liver, but now this same histogram can be used to assess the stiffness in the nerves, the stiffness in the muscles, but what is lacking is the standardization. If more of us get into this and start getting normative data, this would be an eye-opener to all of us, because you can quantify the stiffness in the muscle and correlate it with the modified Ashworth scale and the Tardieu scale. We can also assess real-time dynamic studies and movement of tendons. So you can actually see the ulnar nerve here is moving out of the groove. From here, it has come to here. So in this person, if he develops an ulnar nerve palsy, it is likely to be a problem of the cubital tunnel, and the dynamic study shows that it's an ulnar nerve dislocation that's causing this problem. Don't worry, this patient is asymptomatic because that's my ulnar nerve. When I scanned, I found that my ulnar nerve dislocates, but I don't have a problem yet. And now coming to the M mode in neurology, how do we assess the respiratory capacity of a person? We do a single breath count, we send it for FEV, FVC, but we can actually visualize the diaphragm moving. And when I apply an M mode, which is the motion mode in ultrasound, I get the tracing of the diaphragm. So the one in the middle is a normal inspiration, and this peak here that I calculate is around 2 centimeters or 20 millimeters, which shows that this diaphragmatic capacity is normal. On the other hand, here it is less than 1 centimeter, and now this shows that this person is going for a respiratory paralysis, and we can visualize this diaphragmatic palsy right within our eyes and bedside as well. Now, if a patient is suspected to have vocal cord palsy, what should we do? Every time I wait for the ENT person to come to do a VDL scopy, look at the vocal cord palsy and confirm that there is a vocal cord palsy and show it to the patient. But what do I do nowadays after my neuro rehab training is that put that ultrasound on the thyroid cartilage, you can actually see the vocal cords here. You can appreciate it. The small limbs are the true vocal cords here, and the one here are the false vocal cords. So you can actually see the phonating vocal cords. So it becomes so easy. The moment you see hoarseness, put the ultrasound probe on the thyroid cartilage, tilt it towards the cranium, you can actually see the vocal cords. And here is a patient with a right vocal cord palsy which doesn't phonate. Sciatica, first we do an SLR, we do a Bragages. If it's positive, more likely the compression is at the level of the disc. If it is negative, we do the FAR, BT, PACE and Freiberg. If they turn positive, possibly a piriformis, and then we do the ultrasound. We can actually visualize the piriformis muscle. If it is increased more than 0.9905, then this patient has a piriformis syndrome. Now we are moving to an era where we can visualize things. Now coming to the therapeutics. We can use needling. Once we visualize, we can bring about change within the body that is desirable. So we either use an in-plane approach across the plane of the probe, wherein we visualize the whole needle, or we use an out-of-plane approach where we visualize only the dot. And we can use methods to improve the visibility. Where is it useful nowadays? Few places is that one is the carpal tunnel hydrodissection. So many rehab professionals do it across the world, but we are not connected to them. We don't know that we are able to do these. These are not just steroid injections, but actually hydrodissections for entrapment neuropathies. So you can actually see that this is the needle coming in, this is the median nerve of the carpal tunnel. You can actually hydrodissect with the 5% dextrose from the carpal tunnel. So the one above is the transverse carpal ligament, and we have dissected it from the median nerve, and the one below we are dissecting it from the other flexor tendon. So if there is any tenosynovitis that is causing this carpal tunnel, that again helps relieve the symptoms. And this is done as an outpatient procedure. For 10 minutes the patient can go back home and start cooking right away. And even patients can start driving back to their homes because it's such a painless procedure. And such is the procedure for cubital tunnel hydrodissection. But cubital tunnel hydrodissection, it's not so easy because one, the visibility is not as good as the median nerve, but we can do ulnar nerve hydrodissections for the cubital tunnel. You can see here the hydrodissection of the ulnar nerve that's being done above and below. But in a rehab world, the true ulnar canal is where the Osborn fascias lies. That is the fascia between the two heads of the FCU. And because that's where the maximum entrapment lies. So if you are hydrodissecting an ulnar nerve, we do it both at the cubital tunnel and also underneath the Osborn's fascia, because that produces the best results both electrophysiologically and symptomatically. And we can, for those patients who are adducted in their limbs and we are unable to do hygiene procedures, this is before and this is the phenol neurolysis of the anterior division of the obturator nerve, and then we do the posterior division of the obturator nerve, and then once we do both these, then we can find that the adductor tone is reduced and there is release in the spasticity. What actually the cost of whole phenol bottle is 300 rupees, and you can use it for about 6 months or a year, because you need to just reconstitute 6% of phenol. And when Nirmal Surya sir introduced me in IFNR con to Dr. Navita ma'am, she helped me with all these things, how to inject phenol, because it's a thing which is not commonly done. And even ma'am was suggesting that we can inject phenol intramuscularly. And so the place where I practice is a rural rehabilitation where people cannot afford botulinum toxin. So we started injecting for the flexor digitorum muscles, the FDL, where, the flexor digitorum longus and FHL, with 0.5 ml of 6% phenol, and the results are incredible because it doesn't come back. The dystonic posture that happens in these stroke patients after the stroke, it doesn't come back again after we inject the phenol. And I had tried it for about 8 months or so now, but we have started to collect data because these things are really fascinating. Next is post-stroke shoulder pain, a significant hindrance to the rehabilitation of the patient, but a very easy procedure to start with for any person who wants to start an ultrasound guided intervention, because this is the deltoid muscle wherein we give the IM injection just underneath the deltoid muscle, just above the supraspinatus. You have the SASD bursa, you hydrodilate it, and then you have relief of the post-stroke shoulder pain. So it depends on if your post-stroke shoulder pain is because of the spasticity to the pectoralis, or is it because of the rotator cuff tendinitis, and then we treat it accordingly. So ultrasound guided botulinum toxin, that makes a job much easier. Here we visualize the muscle directly. That also helps us to assess the spasticity of the muscle, and also helps in injecting visualize the injectates where it is going, And one thing that we always say is that EMG, we are able to get to the motor points, whereas ultrasound, we don't know what the motor points are. But nowadays we have standardized measurements as to where the motor point lies in the ultrasound, and we use that to inject the botulinum toxin, and also we use that to inject the phenol as well. And that has been an eye-opener to me in the last year, injecting phenol intramuscularly. But the evidences to it are minimal, but in those patients who are not able to afford it, and that becomes an important thing. And this third eye has been a real eye opener, and it is bound to be an eye opener. And there is a whole new world waiting out there for us neurologists in the realm of neuro rehabilitation, and that's ultrasound and neuro rehabilitation. And if on behalf of the president of IFNR, we have a session that to enlighten on ultrasound, and I hope the session will be finalized, and I invite you to IFNR Con on behalf of the president of IFNR, Dr. Nirmal Surya sir. And I thank Dr. Lakshmi Narasimhan sir and Dr. Nirmal Surya sir for giving me this opportunity, and I thank INTA's team, and I thank for the wonderful props that they had arranged for the quiz, which I failed to thank them yesterday. My sincere apologies for that as well. Thank you, sir. Thank you, Sudhir Shah sir.
I think this would have excited many of you young neurologists that there's something more than just seeing the patient and writing the thing. Botulinum toxin, sometimes I find that hard for the many young neurologists to go into the practice because of cost and its result. But I think ultrasound is something which all of you must learn, and we would be creating every 6-month workshop, ultrasound guided rehabilitation workshop with Guhan, Ujjwal and Arun already been trained, and we want to create that each district there should be a neurologist who could do that, because you know the plastic surgeon, when he do the median nerve release, he charge nearly 1.5 to 2 lakh rupees. The same job you can do it at 10,000, 15,000 rupees and help the patient go back without any surgical intervention, without any complication. So these are the exciting time as we have discussed. Can I have all the neuro rehab speakers being here? We have taken some time, but I think this is very important that as a neurologist, you should be sensitized about how the future subspecialty of neuro rehabilitation is going to be changing. And I would want all of you to kindly, Arun has created this one Google form and a small survey. I request all of you, 25 people, to do pilot survey on this today. It will take about 3 to 5 minutes. It is on the stroke care. We really want to improve upon the rehabilitation in stroke across the country. And then this stroke rehabilitation can expand further into the other neurological disorder. Because once you have established stroke rehab, you can always take Parkinson's disease, TBI, and other disease. So if we can all be here and somebody can take a good picture of us, and I want to thank all of them, the multidisciplinary team which is going to lead the neuro rehab in this country in this next decade. So thank you all for giving this opportunity. Sincerely thanks Sudhir Shah, who 3 weeks ago caught me at IIT Gandhinagar while I was there on a visit, and he said that this program has to be under the banner of IFNR, and I was very happy because I want to propagate neuro rehab. Anywhere neuro rehab is going to improve, we are there to stand with you. Sudhir bhai, thank you very much. Lakshmi, thank you very much for giving this opportunity to IFNR. Over to you.
Thank you so much, sir. So we will break for tea for 15 minutes, and then we will reassemble at 11:15. Hello. Can I have the mic, please? Hello. Yeah. Uh, I request all the respected delegates to kindly settle down. Uh, we will start our inauguration ceremony, and for that, I would request Dr. Sudhir V. Shah sir, Dr. Lakshmi Narasimhan sir, Dr. Nirmal Surya sir, Dr. Vengamma ma'am, Dr. Bucci Raju sir, please join us on the stage. Um, I'll also request Ranga Lakshmi ma'am, Dr. Anand Kumar, Dr. Rajinder Kumar Bansal sir, and Dr. Amit Bharadwaj sir. Please join us on the stage. Dr. Parul ma'am, please. I'll also request Mr. Arun Chadda to kindly come on the stage to assist all the delegates for the lamp lighting. Candles, please.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम् या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः चाड्या पहा शुक्लां ब्रह्मविचारसार परमा आद्यां जगद्व्यापिनीं वीणापुस्तकधा
Diksha and Kiran, please, can we have you on the back of the stage? So this is the list.
Sir, sir, आप sir, आप Dr. Venkatesh, Dr. Venkatesh from Visakhapatnam, Dr. Jayanti from Bengaluru, Dr. Chinmay, Dr. Deepati, Dr. Srija, Dr. Srivardhan, I request Professor Nirmal Surya to come on stage to give the mementos to the Dr. Upputri, Aruna Upputri, Dr. Bala Pradeep, Dr. Bala Pradeep, Dr. Rajinder, come, Bala Pradeep. Dr. Rajinder, your Dr. Rajinder, Bala Pradeep. Dr. Rajinder is there? Okay. Dr. Kaushik, Dr. Sanjeev Kumar, Dr. A.N.S. Madhuri, Dr. Kirti Raj, Dr. Sai Arun, Dr. Ankit, Dr. Ankit, your doctor? Arun, Sai Arun. Dr. Ankit is there? Dr. Arun Shivraman. Dr. Hitav Someshwar. Dr. Guhan Ramamurthy. Dr. Preeti. Finish off, sir. Preeti, madam, please come. Guhan, sir, Guhan.
Dr. Anusha Mekla. Dr. Anuhaya. Miss Devanshi Sharma. Dr. Ishwarya. Dr. Amrut.
Dr. Amrut. Yes. Today. Dr. Parul. Madam is the local Goa. Previously she was attached to Goa Medical College. Now she is attached to Manipal. Manipal is Goa, and she has consented to have a clinical discussion with Mufti. So we are honored. My shawl also. Give me a shawl also, madam. Sir, I now request Professor Vengama madam to come on stage. Dr. Sriranga Lakshmi. Dr. Sriranga Lakshmi. Rajinder. Dr. Buchiraj, sir. The next is this.
राजेंद्र है वो सामने ही यार खड़े कर दी
Dr. Amit Bharadwaj.
Dr. Anand Kumar. Dr. Anand Varnasi. And ma, get me 2 shawls, no? We want to honor her. Anand is not there. Left, Anand left, his flight is there, his left. And now, Arun Siddha.
Sir, Amit Bharadwaj, sir.
Huh?
Amit Bharadwaj.
Dr. Amit Bharadwaj. Next to Dr. Shankar. He's here. He's sitting there. He's there. Get it ready.
Shankar sir, Shankar sir. Shankar sir का
कौन है कहाँ है
Shankar sir is there.
पहले की बात
Come on, Dr. Shankar. Huh? Shankar, no? Dr. V. Shankar.
डॉक्टर अंकित पंजवानी
Dr. Ankit.
Now I'll call Mr. Arun Chadda to please come on the dais.
I request Dr. Manoj Kumar please come on the dais to honor our directors of this program, please. Our course director, Dr. Lakshmi Narasimhan sir. Give a good round of applause. Our second course director, Dr. Sudhir Shah sir. And the name without him we can't do this program. That is Dr. Nirmal Surya sir. Please give a good round of applause.
Thank you so much, Arun sir. Please join Sudhir sir and Ellen sir on the stage.
you know, the back end of the entire team, the credit goes to Dr. Manoj and Dr. Arun Chadda, and please come, Dr. Shweta. Shweta, please come. Miss Shweta, she's done all the groundwork, including every logistics of this place, and the entire team. I'm very proud. And I request sorry. I think now all these episodes, we have brought it, all the 50 episodes, we have brought it in the form of a book, so that there might be useful, discussions might be useful for the residents. We are waiting for the, yes, please get the, we're waiting for the consent of the few authors to get it published, the entire clinical details. No, the videos are all there. We uploaded all the clinical content, bearing the images and all on the videos, will be there on the website, which we have already launched. It will be functional from a username, password will be given for the doctor's access only. So that will be given for them, for the students to view all the episodes. And the book is,
So friends, you will have all these 50 episodes in the booklet form, as well as you will have everything on YouTube. So this will be a permanent archives for total knowledge based learning on secrets of neurology. I'm sure each of you will value this important archives, and please spread the message across India for all students, even abroad, because as you know, these are most wonderful cases, most wonderful discussions and deliberations, and at the end there are expert comments and questions. So this is a legacy for the time to come. So please use it in the best possible way. Thank you very much for all your support. Thank you.
now I, ready, sir. Not a Mac. So the residents, for all the residents, we have the Dijong's neurological examination. One by one, you can come and collect. The residents can come and collect the book. Please, Aishwarya, Madhuri, for all the residents and even junior consultants who wants to have the book can come and collect. Anybody wants to have the book can come. definitely send it across. For all of you, my work. India. Huh? No, sir, the Chennai room. Yes, it would. Room sir. Sir, sir, charge is not there. I'll request a clinical case to start, and meanwhile I'll get it. Now I request Dr. Parul come to the dais, and Dr. Akshay, no? Amrut come to this, and I request connect one. Mayura. 1312. Dr. Amrut, Associate Consultant, Manipal Hospital, Goa, DRNB from Gangaram, worked in GB Pant, Neurology Senior Resident in Indraprastha Apollo, postgraduate in Internal Medicine from Tata Jamshedpur, papers in line Neurology India. He has got a plasminogen activator inhibitor mutation in acute young stroke, NES-CAV syndrome, hereditary spastic paraparesis case report, and various poster presentations and welcome to you, Dr. Amrut. Dr. Parul Dubey, Consultant Neurology, Manipal Hospital, Goa. She has been with Goa Medical College, and she has been a consistent faculty in SHINE. And she has got gold medals in pharmacology and general surgery. Areas of interest is neuromuscular, associated with the book Clinicians Approach to Neurological Disorders. Speaker, faculty in National Neurology Conferences, Neurological Society of India, Coimbatore. SHINE from 2015 to 2020, contributed to the most prestigious neurological specialty SETEX subsection Yearbook of Neurology, co-authored 2 subjects in Guidelines of Vertigo, awarded gold medals in pharmacology, general surgery, and a distinction in biochemistry, 20 publications. Welcome you, madam. And Aishwarya, resident from Sri Ramachandra, she will come and present the case.
A very good morning to everyone. At the outset, it feels so good to have the extended neurology family from all over India here in Goa. Yes, sir. So please. Yeah. Yes, sir.
So this is the
You see, all these institutes have presented cases in this last 4 years and no more, and we have decided to give awards to eminent teacher category, best institution in case discussion category, and best clinical discussant, that is resident of the year. So year wise, first 2020-21, then 21 22 and 2023, and now this year will 23, 24, and this year will give next year. So, first year category 1 Eminent Teacher Award for Secrets of Neurology year 2020-21. The award goes to Professor Satish Khadilkar and Dr. Subhash Kaur. Their presentation was in that year. Category 2 Best Institute in Case Discussion of the year 2020-21, CMC Vellore and DMCH Ludhiana. And the best clinical discussion of the year 2020-21, one is JIPMER, Dr. Rajeshwari and Dr. Saurabh Jain, and second, Dr. Srivarda, Madras Medical College Institute of Neurology at Chennai. So please give a big hand. And now I request Professor Lakshmi to give out other awards.
Yes, thank you. Thank you so much. Thank you. Thank you, sir. For the year 22-23, the Eminent Teacher Award goes to Professor Vivek Lal and Professor Vivek Lal from PGI Chandigarh and Professor Buchiraju from Vaisak Medical College. So the best institutes of case discussion the year 21-22 goes to Institute of Neurology Chennai and King George Medical College Lucknow. And the best clinical discussant of the year 21-22 goes to Dulari Gupta Pune and Balaji G Changalpat Medical College. And the year 22-23, the Eminent Teacher Award goes to Professor Anand Kumar from Amrita Institute of Cochin and Professor Venkamma from SWIMS Tirupati. And the best institutes in the case discussion 22-23, Sri Chitra Trivandrum and IGMI, Professor Shailaja under the leadership of Professor Shailaja, and IGMER from Patna under the leadership of Dr. Ashok Kumar Singh. Best clinical discussant of the year 22-23, Dr. Shushma from Andhra Medical College and Dr. Oshin Mantro from Tanda, so Oshin Mantro from the Tanda Medical College in Dharamshala. 23-24, the Eminent Teacher Award goes to Achal Kumar Srivastav from All India Institute of Medical Sciences and Professor Netravati from NIMHANS. The best institutes in case discussion, St. John's, Bangalore and Sri Ramchandra Medical College, Chennai. Best clinical discussants, Dr. Ridvik Ramesh, Dr. Philo Hazina and Dr. A.N.S. Madhuri from Apollo Hospital, Chennai. Thank you. So all the plaques, certificates, everything will reach the concerned institutes in person. Thank you. Thank you for the cells. Now I request Dr. Parul Dubey to take over. I'm sorry for the interruption.
So we will begin with our case presentation, but before we do that, I want to express my deepest gratitude to Professor Dr. Lakshmi Narasimhan sir, who has always mentored me from a distance by giving me so many opportunities to learn. I'm very, very grateful to you, sir, always. So when sir asked me to present a case, it felt like an honor, and I'm really honored to be present here in front of you and be presenting this case. My thanks to Dr. Sudhir Shah sir, Dr. Nirmal Surya sir, and the organizing team of INTAS. So we will be starting this case. We wanted the case to be discussed openly and in a relaxed way. So the way we have decided to present it is that Dr. Aishwarya will be presenting the clinical details. I will try to give my assessment in between. We'll try to make the case flow like that. And Dr. Amrit will be presenting the lab diagnosis of the case when we reach that point. And of course, the case is open to discussion throughout. So I would request the residents and all my seniors to please ask questions and give their inputs in between. as they feel. So, Dr. Aishwarya will start the case now.
This is about a 47-year-old lady who is a nurse by occupation and a known hypertensive on regular medications, presented to neurology OPD on 30th of July with 1-day history of acute onset of weakness of right upper limb and lower limb with deviation of angle of mouth to left and slurred speech. Vitals, pulse was regular 78 beats per minute and blood pressure 130 by 80. Patient on examination was conscious oriented, speech mild dysarthria was present, right UMN facial palsy was present, and power right upper limb and lower limb were 4 by 5 and left 5 by 5. Deep tendon reflexes were 1 plus on both sides, plantar extensor on right and mute on left. Sensory was normal and cerebellar examination was normal.
So, what I get from this clinical history is a 47-year-old lady who is a nurse by profession, who is a hypertensive, and she has presented with an acute onset right-sided hemiparesis, which is pure motor, involving the right upper limb and the lower limb equally. So what I gather from this presentation is quite a common one that we all encounter in our OPDs always. So it seems to me like a lacunar stroke, most likely, of course, left hemispheric, subcortical, because there are no features to suggest any cortical involvement, unlikely brainstem, and mechanism seems to be, if it's a lacunar stroke, then small artery occlusion. Things look all right at this point. So the approach would be to do an MRI, of course. So Aishwarya did that MRI.
MRI brain was done, which was showing acute non-hemorrhagic influx in the left parietal and in the right precentral and postcentral gyrus and in the left centrum semiovale.
Okay, so what the scans suggest to us, what we see here are bilateral infarcts, although the presentation is on one side. So possibly whenever there are bilateral infarcts, as per the etiology, we always think that it could be an embolic stroke. It may be cardioembolic because more than one vascular territory is involved. That is what I would think at the end of this MRI. Next.
So CT angio neck and intracranial vessels were done, which was showing right ICA diffuse moderate narrowing extending from 1.5 centimeters proximal to the carotid bifurcation till its distal end, causing 70% luminal narrowing, and right MCA occlusion of M1 segment and proximal M2 segment with distal reformation of distal M2, and rest of the segments were normal, where M1 segment was replaced by few collaterals, which was likely suggestive of a moya-moya disease. And left MCA, there was a short segment luminal narrowing in M1 segment, which was 60 to 70% for a length of 1.0 centimeters, and proximal M2, which was 20 to 30% for a length of 0.6 centimeters. And rest of the segments were normal.
So what would one think about the etiology of the stroke at the end of the CT angio? Yes, so if the audience want to.
Almost near the carotid bifurcation on 1.5 centimeter, just proximal to the carotid bifurcation, and also M1 and M2 segment, and a short segment in left M1.
Any inputs from the audience?
Sir, Butchiraj sir, what is your any thoughts, sir? Now, during the COVID, we got lot of bifurcation infarcts, bilateral. The COVID also had repression of the moya-moya, that somehow it has some genetic things happened, and a lot of, especially in children, lot of moya-moya mimics happened during COVID, and you will be surprised there was a huge waiting list of moya-moya. In Sri Chitra, the waiting list was about 8 months for revascularization. Names also, it is about 6 months. So they were not able to get it, and secondly, the revascularization cost outside is also per side. It was around 5-10 lakhs. Easily, on bilateral, it will be about 10-15 lakhs. A lot of people suffered. I know I had to move pillar to post to get the revasculated for poor patients. So that was one of the things. So this is almost near. Can you tell any of your thoughts, sir? This patient didn't have a COVID. No COVID. Mike, please.
Acute right hemiparesis 3 years ago, 1 month after COVID vaccination. She had a corresponding similar lesion in the thalamo-capsular region, in fact. And at that time, the angio was normal. She is 24 years old and this presented 3 years ago. Recently, she came back with again right hemiparesis and the same distribution, same presentation in the same area. But the presentation is probably different. She had now multiple white matter lesions, but clinically she had hemiparesis on the same site. So, and it's a corollary, but that's not vascular. It doesn't appear to be vascular because she had other multiple white matter lesions which look like demyelination, and detailed investigations revealed even though she didn't have any systemic complaints, she had SSA positive twice. It was done in our place. It was a double positive systemic SSA antigen. Anti-Rho was positive. So I thought it could be COVID related or post vaccine, but
Okay. So I'll go ahead. So what I thought after seeing that CT angio, the differential diagnosis that I would consider would be of some CNS vasculopathy, possibly a vasculitis. She's a hypertensive, so atherosclerosis of course remains a differential, or moya. So can it be moya disease? Even the radiologist has given the possibility of moya disease. So here I can just pose a question to the audience. That it is moya disease or syndrome. So what is the difference between moya disease and moya syndrome? If I try to analyze, the age group for moya disease is between 5 to 9 years and 45 to 49 years. So she does fall into that age group. But we know because of the collateral formation, the adults most often present with hemorrhagic presentations, but TIAs can happen, ischemic presentations can happen. So the story can fit into the moya disease. But whether it is moya disease or syndrome, any resident would like to answer that? What is the difference between moya disease versus moya syndrome? Okay, I'll go ahead. So moya disease is an isolated, chronic, usually bilateral vasculopathy of undetermined etiology, characterized by progressive narrowing of the terminal intracranial portion of the internal carotid artery and the circle of Willis, and it has a genetic basis, as we all know. While moya syndrome can happen as a phenomenon due to any neurological or extra neurological condition which may be inherited or acquired, as we see in this box, for example, sickle cell disease, neurofibromatosis, Down syndrome, cranial radiation, etc. And moya, the famous puff of smoke, is that fragile network of collateral vessels which forms because of chronic ischemia at the base of the brain and the basal ganglia. So that's just because moya is a possibility. So here we just went into that. In this patient, there were some collaterals, but not many collaterals. So still, can it be moya? The possibility of moya cannot be ruled out until we have done a DSA. So DSA was not yet done in this patient, and CT and MR angio can miss the collaterals because of the low flow and lesser spatial resolution. So still the possibility of moya syndrome exists. So now, if I'm thinking of a CNS vasculopathy which has led to a probable moya phenomenon, then what all conditions I would consider? So all the systemic vasculitis and connective tissue diseases, that would come into picture. We have to think of infections, as Sir just suggested that COVID presented with a moya phenomenon. So we have to think of viral, bacterial, fungal, parasitic infections. Neoplasms, and there may be other miscellaneous causes like fibromuscular dysplasia, Moyamoya disease, TTP, and the rarer primary angiitis of CNS and reversible vasoconstriction also come into the differential diagnosis looking at the CT angio. So that's how I thought. So any other relevant history which we have not yet mentioned should be taken, or clinical science should be looked for based on this knowledge that we have gathered so far.
So considering vasculitis, there is no history of fever, skin rash, cough, fatigue, weight loss or genital ulcers, no joint pains or swelling, photosensitivity, swelling in the neck, axilla, eye redness or eye pain, and no menstrual irregularities, recent travel history or insect bite, family history was negative for stroke, and on examination, no skin rash, all peripheral pulses were well felt, normal and equal on both sides with no bruit, blood pressure was normal in both arms, and no lymphadenopathy or organomegaly.
So all the vasculitic relevant history was more or less negative. We didn't become wiser with any of these points. So Aishwarya further investigated the case.
Patient was investigated further, whereas CBC, coagulation profile, RFT, LFT, thyroid function test, sugars, and since the patient was under 47 years, a cutoff for lung stroke, fasting lipid profile, vitamin B12 levels, serum homocysteine, folic acid, and immune workup, ANA, ANCA, APLA, viral markers, VDRL were everything negative. And considering cardioembolic, 2D echo and 24 holders were done, again it was negative. So interventional radiology opinion was taken where they advised DSA after 4 weeks. Since all the workup for hypercoagulable state turned out to be negative, we discharged the patient. With dual antiplatelets and high dose of statins. Considering both sides, there was occlusion like in ICA, so we wanted to keep the blood pressure a little high. So at the end of the discharge, patient was around 130/80, so we didn't add any antihypertensives.
So I would ask the audience, everybody is satisfied with this management?
Or anything else could have been done?
Transesophageal echo was planned. What was planned, but what wasn't done as yet. So it seems a good plan to me that double antiplatelets was started, high dose statins at this point. I couldn't think of anything more. And things look all right as per recommendations. But then the patient came again on 12th July.
So this was after 4 days after discharge. Patient returned with worsening of weakness of right upper limb and worsening of speech despite being on good compliance to antiplatelets. On examination, patient was oriented and speech, initially she had mild dysarthria, now it became moderate to severe dysarthria with persistent right human facial palsy. And power, there was worsening. Initially it was 4/5, now it was 3/5 in the right upper limb, whereas lower limb remained same. And DTR was 1+ on both sides and plantar extensor on right and left was mute and sensory was normal on both sides.
So now the patient has come with a worsening of hemiparesis of the right side in the same territory. So what are the possibilities why it happened despite a good compliance to antiplatelets? Because she has stenosis on both sides, whether some hypotensive episode took place in between and led to more infarcts, but she was not wisely put on antihypertensives on discharge. Or there is some resistance to antiplatelets, that's one thought I had, or the vasculopathy that she's having is worsening, or there's more than one etiology we are dealing with. So would you like to add something?
Any thoughts from the floor?
Ma'am, we did not have any basis to start, at least the vasculitic workup and the inflammatory markers, ESR, CRP, they were all normal. The age group. Yes, not typical atherosclerotic, yes. We might have, yes. So, okay, that point is taken. But we know that antiplatelets, yes, of course, are not 100% effective in preventing recurrent cerebrovascular events, and the phenomena of antiplatelet resistance is also described. So, okay, we can pacify ourselves. Okay, something like that might have happened. But Aishwarya got a repeat MRI done and it showed what?
So the repeat MRI imaging was showing new infarcts in the left frontoparietal region and in the centrum semioval coronary data and also in the temporal and lentiform nucleus. Initially, it was only restricted to the precentral and postcentral gyrus and on the right side.
Okay, so the infarct also has increased on the MRI and the CT angio is also showing something new.
CT angiogram done. Initially, the left MCA, which was only 70 to 80% narrowing, now had a complete non-opacification involving M1, and the proximal M2, which was only 20% initially, that also was complete occlusion with distal reformation. But there was no interval change in the right ICA or the right MCA.
So the vasculopathy has definitely worsened. Now there's a complete occlusion of the left MCA. So we are dealing with some process which is ongoing and causing more and more vasculitis. So what was done now?
So patient was now started on a single antiplatelet with anticoagulation, and to test for platelet resistance, we have done platelet aggregometry. With aspirin, it was strongly present, 2.1%, and with ADP, it was mildly present, 47.4. And ESR CRP repeated at this point, ESR was 41 and CRP still was negative. And we have done repeat 24 holters, which was normal.
So, any more suggestions what she should and we should do now? Okay, so now MR vessel wall imaging was done. So that seems to be a good step. What you found on the MR vessel wall imaging?
So the MR vessel wall imaging, right ICA was showing moderate to severe diffuse narrowing involving involving the ICA with wall thickening and enhancement. Even in the left ICA, there was mild wall thickening and enhancement. Bilateral ICA, there was occlusion of the proximal segments with wall thickening and enhancement. And ACA, there was wall thickening and enhancement present, whereas carotid bifurcation, the vertebral, basilar, and PCA were normal.
Okay, so here we have wall thickening and enhancement occurring in most of the blood vessels which were involved. That is interesting, and suggestion of medium vessel vasculitis, as Madam also suggested, is there on vessel wall imaging. So here may I have a question that how does, is it still moya moya? The question is, how does vessel wall imaging help? I mean, vessel wall imaging can help diagnose vasculitis, but what other conditions it can help us to diagnose in strokes? Any answers from anybody, from the residents, if at all they are there? Okay, so by definition in moya moya, terminal ICA is involved, but here we see that even there's a severe diffuse narrowing in even the cervical petrous ICA. So that goes beyond the scope of moya moya disease, as far as I understand it, sir. Because it's mostly, by definition, it goes into the terminal ICA and proximal MCA. And vessel wall imaging in moya moya typically demonstrates concentric luminal narrowing with no or minimal enhancement of the vessels. Here we are getting a thick enhancement, so that seems to be out. And there is no outward remodeling, which is seen usually in vessel wall imaging in atherosclerosis. So possibly we are not dealing with an atherosclerotic condition causing this vasculopathy here. So the possibility of vasculitis holds. So which conditions, okay, this was the question which I asked earlier. And the conditions which vessel wall imaging can be used to diagnose are intracranial artery atherosclerosis, dissection, moya moya disease, vasculitis, and RCVS. Okay, so what was the further course? What was done?
So considering medium vessel vasculitis, we started her on low-dose IV corticosteroids, methylpred 250 mg BD, and rheumatology opinion was taken. And the initial workup by ANA and everything turned out to be negative. So we had a secondary investigations of medium vessel vasculitis where C3, C4 cryoglobulins, LA23, HLA-B51 were done, which were again within normal limits. And other artery, axillary, temporal, and renal artery were done, which were also normal. At this point, after starting a low dose steroids, patient clinically stabilized. So we discharged her on 23rd July with ecosprin 75 mg, and since the patient was having clopidogrel resistance, we switched her to ticagrelor 90 mg BD, and low dose Vislone was started and she was discharged.
So now I think we are on the right track. We thought there was some clopidogrel resistance, so it was taken away, and ticagrelor was started, and small dose Vislone also is started. Now we think that the patient should be all right.
Dr. Aruna suggested you started steroids also. What is your thought process? Anything better could have been done? Everything now. LAA all 23, all negative, sir.
Okay, but here we are again there with the third visit on 25th of July with further worsening.
So the patient came back again within 2 days with worsening of right upper limb weakness and worsening of speech. On examination, patient was conscious. Initially when she had severe dysarthria, now it was reduced to only verbal output where only comprehension was preserved. Right human facial palsy still was present, and the right upper limb initially, which was 4 by 5, then reduced to 2 by 5, now it is 2 by 5. And lower limb initially was 4 by 5, now it's 4 minus by 5, whereas left was still normal. And DTR 1 plus on both sides. Plantar was extensor on right and mute on left, and sensory was normal. So she was started on high dose steroids at this point of time. And we repeated a MRI brain where it was showing new infarcts involving the left caudate, left gangliocapsular region and left coronary aorta, whereas the MRA was showing non-visualization of M1 and M2 and pruning of the cortical segment of the left MCA and reduced flow in cervical, petrous, cavernous and supraclinical segment of right ICA, and the reduced flow in right MCA and paucity of the cortical branches.
Okay, so things have worsened despite our steroids. So they went ahead with a rheumatology review.
So rheumatology has advised to start her on another immunotherapy, cyclophosphamide, with high dose of IV steroids, which were initially started and we continued, and we still continued ecosprin, ticagrelor 90 BD with statins.
I have the unfortunate consultants. Every time, you can see more and more investigations and convincing them on a corporate setup for. So it was really nightmare because they were those so dissatisfied that you are not able to find out what is causing. Every time the patient comes back with worsening, and so this is the stage. Anything else, sir? Anything that come? Any other things that come to your mind? Yeah. So the next step was to go for a biopsy for for the vasculitis, as madam suggested, is a lymphoproliferative. Any other things, madam? The vasculitis can be infective or can be inflammatory or can be neoplastic. So any other thing which comes across your mind?
Okay, so now we were happy at least that we have covered with cyclophosphamide, but more surprise.
So the patient, despite on being IV high dose steroids, this is the 4th day after starting the steroids, she was again had a worsening of weakness of right upper limb, where now initially the power was 2 by 5, now reduced to 1 by 5. Speech remained the same and lower limb power remained the same. So we repeated an MRI again, which was showing increase in the volume of the infarcts in the left frontal caudate and coronary aorta and insular region, but MRA there was no interval change.
So more infarcts are happening, and whatever we have done till now is not stop the process, whatever vasculopathy is occurring. So is it really a medium vessel vasculitis as suggested? It's not responding to immunotherapy, and clinically we are not getting any vasculitic or infective features.
Lymphoma, your diagnosis, madam. Some response would have been there with steroids, pulse steroids. There's nothing there. So, not even a small, it is kept on worsening. So
Yeah, so that was the thing. So what should we do now? Yes, CSF is something that we have left out till now. 47-year-old, so it still falls in the category of the young stroke. Okay. So Aishwarya got a CSF done.
CSF done was showing cells normal, less than 5, so total cells of 3 and neutrophils 1, lymphocytes 2, proteins were normal. Glucose 80, ADA 4.6, gene expert was negative. Considering infection, meningoencephalitis panel was done, which was again negative. And viral HSV 1, 2, VZV was done, which was negative. To rule out malignancy, we did a whole body PET, which showed no malignant focus.
Now CSF is also not guiding us anywhere. Everything is negative. There is no pleocytosis. Sugars are normal. Meningoencephalitis panel is negative. CSF PCR for HSV and VZV is negative. For malignancy, whatever they could do, they have done.
What's your thought process? Fundus is normal. Fundus normal. No retinal branch, nothing was there.
Any thoughts?
Any other thought process? Madam? Madam?
No, madam. No drugs and toxins, no? As far as the history, we don't have any.
No family history was there, nothing to suggest.
Yeah.
50 years, first manifestation.
VDRL negative.
All negative.
VDRL was negative. Yeah.
HIV, VDRL, all those screening was negative. Yeah. The surface antigen, almost entire workup was.
No new infarcts on the right. Yeah.
First one had a right side. Yeah. All other things are worsening, only was on the left.
And occlusion was happening on the left.
More and more worsening on the left, but she had
initial
imaging features on bilateral.
Initial MRI, first MRI ma'am was showing bilateral infarcts. Now only on the left side. But in the vessel wall imaging that we had cervical.
50% stenosis on either side where the CT angiogram.
Yeah. So now just to give a timeline, although we have gone through it.
So summing up the case, she is a 47-year-old with known hypertensive. She presented on 30th July with worsening of weakness, again on 12th July, and despite being on good antiplatelets, dual antiplatelets, and 25th July after being on a low dose of steroids, and again on 29th with full dose of steroids. And the imaging was showing this increase in worsening of the infarcts despite being on good antiplatelets, anticoagulation, and immunotherapy. And even the vessel wall imaging was showing a worsening despite the same medical management was continuing.
So that's how it was. Quite a difficult case, as sir said.
Sir,
so
what is
what next?
Madam?
Autoimmune profile, madam,
all
was
negative,
negative.
madam. LIA all negative.
All was negative. So now,
Sir? Biopsy. So it's the patient were not willing, sir. In fact, they were not willing even for the CSF. They were completely fed up. They wanted to get rid of me. Meanwhile, they took all the records and shown to 4 or 5 people there in Chennai also, and then they came back and they didn't have, the other people also didn't give much options, so they finally agreed for the CSF, sir.
So,
yes, madam.
Contrast MRI.
It was normal, no meningeal enhancement. Nothing was there.
So the state is like this. So, to our rescue comes the experience of our teachers and clinicians. So, which makes our faces relieved. So what extra was done on the CSF and the serum, and that was really something wonderful.
So the CSF, VZV, IgG was elevated. The cutoff is 120. For the patient, usually in CSF it should be negative. She had 83.72, and serum varicella zoster IgG was 11,427. The cutoff is 120, and serum albumin was 2.9, and CSF albumin was 11.2.
So at this point of time, I should give credit to Dr. Ridvik. He is working on this varicella vasculopathy, and then Ramchandra is center in collaboration with varicella vasculopathy with what is that US center? I think some famous center. One lady is Nagel or Nigel. So Nagel, and she has written almost 50 Green Journal articles on varicella vasculopathy in the last 2 years. Almost 15. and almost in every publication she will be there. So Dr. Ridvik got interested and he is also working on that, and we have a nodal center for this varicella vasculopathy, and that is why this came. I never knew that the varicella vasculopathy, it is the IgG which is more important than the IgM, and even with or without prior history of exposure to varicella also the cases can present, and all kinds of, I mean, it's one of the new entities which is really emerging, one of the infective causes of stroke.
Yes. PCR was negative, madam.
PCR was negative, madam.
This is IgG. Yeah, this is
CSF IgG.
So we are dealing with a varicella vasculopathy causing recurrent ischemic stroke. What treatment was provided to the patient?
Patient was started on IV acyclovir 750 mg TDS for 2 weeks and later discharged with oral for 1 week 800 mg TDS with ecospirin, and retrospectively on analyzing, whenever the patient was on anticoagulation, she was not worsening. So we switched over to a single antiplatelet and anticoagulation. So discharged her with dabigatran 110 mg BD.
Okay, so the patient has shown no further worsening finally. So we are happy doctors now. So I will just take you through a few slides about the varicella vasculopathy. So as we all know that varicella zoster virus belongs to the herpes virus family. It's a human neurotropic virus, and 95% of the population is exposed to it. Primary infection, chickenpox causing the vesicular rash, but it becomes then latent in the ganglionic cells throughout the neuraxis. And whenever the cell-mediated immunity declines, then it can spread peripherally to form the herpes zoster rash, or it can go centrally to the brain to cause meningoencephalitis, or to the cerebral arteries to cause vasculopathy. Even temporal arteritis can occur. It can go to the spinal cord and cause myelitis, and spinal cord arteries to cause spinal cord infarctions. It can happen with or without rash. The central spread can happen in the absence of rash, and it can cause not only vasculopathy, vasculitis ischemia, it can cause hemorrhages, aneurysm formation, vessel dissection, and also venous sinus thrombosis. So the spectrum of involvement of CNS by varicella zoster is big. We have to think of it. What is the risk of stroke after a known varicella infection, zoster infection? Within 30 days of zoster infection, stroke risk increases by 2-fold, and most varicella vasculopathies develop within 6 weeks, but can be up to 4 months after the rash. But you see rash only in 63%, so 1/3 do not have the rash. Risk may remain increased. In some cases, it has been mentioned up to 11 years from the zoster diagnosis, and risk is higher in older age groups, immunocompromised people, those who did not receive antiviral treatment during the index zoster infection, and herpes zoster ophthalmicus is more associated with the risk. So what does varicella zoster do to the blood vessels? It affects the vessels multifocally, affects both large and small arteries, and MCA and ACA have more dense trigeminal innervation, so more affected than the posterior circulation, but it can be affected. Posterior circulation also can be affected, but anterior is more. So after the primary infection, when the varicella becomes dormant in the ganglia, when the cell-mediated immunity declines, then on reactivation, it spreads to cerebral arteries first transaxonally, and later on transmurally. So through the adventitia, it goes to the media and destroys the smooth muscle cells there, destroys the internal elastic lamina, and finally leads to an intimal proliferation. So that's how the vessels get affected. There's a thickened intima, new intimal proliferation, loss of medial smooth muscle cells, and internal elastic lamina disruption. Varicella causes the problem by direct infection as well as inflammation. And the most characteristic thing is transmural granulomatous inflammation with multinucleated giant cells. So that is the pathology. And as we saw in this case, it can present as stroke, focal deficits, but it can also present as isolated vision loss, headache, and cognitive impairment of a protracted type. So we have to keep our eyes open for varicella more often than we do usually. Yeah. So what are the typical radiographic features of varicella vasculitis? If I go to the findings in the parenchyma, gray-white matter junction is affected. Areas can be single or multifocal. Deep areas are more affected, white matter is more affected, and the infarcts are ovoid and well-defined. The angiography findings are like showing segmental stenosis with poststenotic dilatation, which is most characteristic. Vessel wall enhancement, as was very clear in this case. There may be a diffuse irregularity, and small and large vessels are affected simultaneously, and there may be a moya-moya pattern, which was so in this case. About the lab diagnosis of varicella, I'll call Dr. Amrit to speak on that.
Thank you, ma'am. So when we talk about the lab diagnosis of this varicella zoster, it all started from the year of 2007, where M.A. Nagel and the co-workers started working upon these cases. In the year of 2007, 8, and 9, continuously 3 articles were published. In the first article, they had studied 14 cases of varicella zoster vasculopathy, where the 8 of them had a PCR positive along with the rashes. In the very next year, they had again presented a case series of some 30 patients, where 23 were published and 7 were unpublished articles. In that case, in one case, they have monitored the case for totally 50 days. They have done the PCR at day 7 as well as the immunodiagnosis, and at day 14 and day 50. So in 2019, Lancet has published a very beautiful article compiling all these things. What we do see in a case of a varicella zoster vasculopathy, there will be a most common thing will be the mononuclear pleocytosis, which is again seen in 2/3 of cases, and CSF protein will be elevated. RBC and the oligoclonal bands, which are specific to varicella zoster, could be found. When we talk about the nucleic acid amplification test, that is viral DNA detection, this could be possible only in first 2 weeks. Rather, the Nagel has published that it is possible only in the first week, in fact. This is not the similar case with HSV, where it is the HSV PCR we sent for the detection, and we have a lot of studies which are correlating with the gold standard biopsy. So here what we see, the PCR for the VZV DNA is possible in the first week, and it has come out to be negative in the day 14 and day 50 in the case series which was published in 2019. Thank you. So when we talk about the immunodiagnostics, it comprises of 2 things. One is serum immunoglobulins, that is IgM and IgG. Second would be CSF, IgM and IgG. Another thing is the IgG index, where we see the serum immunoglobulin and CSF immunoglobulin. We divide this through the serum albumin and then the serum CSF albumin. That is the most common thing what we see in to detect the inflammatory things. So in case of a varicella, the VZV IgM rises in a few days after the VZV reactivation, but it is less reliable for the diagnosis because it can persist only till 3.5 weeks. When we talk about the serum varicella zoster VZV immunoglobulin, it could indicate the previous infection or immunization, or it can be positive in cases who has received the blood products. So again, it lacks the diagnostic value. So and another thing would be the serum to CSF ratio, which is nothing but a kind of IgG index. But again, the laboratory values vary for a particular laboratories, so we cannot depend on this here. So when there is a negative VZV PCR, so it becomes that the presence of an intrathecal synthesis of the anti-VGV IgG in the CS will be the most accurate diagnostic value. So when we compile all these things, so VZV IgG has the better utility in the diagnosis. Now, there is another entity, what we usually face, most of them have answered many of the multiple choice questions. Another virus resembling this would be the West Nile virus, where we depend the diagnosis based upon the IgM. And the one more entity, it is the COVID, in fact, actually. So I did my neurology from Sir Gangaram Hospital. So my thesis was neurological manifestations of the COVID-19. In the first and second lockdown, under the guidance of M. Gauri Devi ma'am and Dr. C.S. Agarwal, I had seen around 350 cases of COVID virus presenting with the various neurological manifestation. So in Gangaram, we were doing, along with the PCR, COVID, IgM, and IgG. So that was another disease. And the inclusion criteria in my thesis was patients who are presenting with the neurological manifestations after 3 weeks of the COVID. So rest of the cases were excluded. So in that also, we could able to find out that it is the CSF IgM COVID rather than the COVID PCR. So to summarize, the varicella zoster IgG has the better utility in the diagnosis, ranging up to the sensitivity where the VZV PCR would be sensitivity will be 30% and the VZV IgG would be sensitive in about 93% cases. Confirmatory diagnosis is made by diagnosing the CSF intrathecal production of the VZV antibodies, which can be detectable after 2 weeks, and VZV DNA, which is possible in the first or second weeks. So in any case where you are doubtful or you are strongly suspecting based on your clinical and then the radiological features, one should order CSF VZV IgG, IgM, and serum VZV IgG and IgM along with a CSF VZV PCR when you are strongly suspecting the infection when they are presenting with the rashes and all. As we don't have a lot of data on this, only if both CSF, VZV, IgG and PCR are negative, one can exclude the diagnosis. Thank you.
So that's really interesting. Yeah.
But
Yes, ma'am. It.
That's what. Yes, the thing is not episodic. She never improved, but only thing the weakness worsened when they were when she was when we were the moment we started tapering, the steroid didn't have a response. We started tapering the steroids. Again, the worsening started. Even cyclophosphamide, it worsened, madam. So worsening. Immunosuppression worsens the any patient who is on immunosuppression worsens strongly. I think you should think of this.
In fact,
and this was definitely now. Almost how many? 6, 7. We have a series about 10 cases, madam. We got and we are writing it up. So fairly in about 4 months we have got. Once we started suspecting this, you will start seeing more and more cases, madam. That's what I personally felt is initially we never had. This was not in our differential diagnosis at all. Now more and more cases start thinking about it, and acyclovir is now become one more weapon in stroke. Yeah, she's very much improved.
So, may I go? Yeah. So, hot points for VZV vasculopathy, if we just, for the sake of discussion, the patient is immunocompetent, but it can occur in immunocompetent patients, individuals also. There was no rash, but as we already saw in 1/3, the rash may be absent. CSF had no pleocytosis, but again, 1/3, the rule of 1/3 seems to be going in this, there's no pleocytosis. So still, we have to suspect varicella vasculopathy. So when to suspect? When to suspect? There's no consensus as to which patient with CVD should be suspected for varicella vasculitis testing. But if there's a cryptogenic stroke after detailed workup, as in this case, with a recent history of varicella or zoster with or without rash, that too will be a very good and clear sign. But when we don't have it, then there's a paucity of traditional vascular risk factors and recurrent stroke despite optimal medical therapy, as in this case, and infarcts at gray-white matter junction on MRI may suggest arterial narrowing in distribution, which is atypical for atherosclerosis, may suggest immunocompromised individuals, we should think of it more. And in cases of multifocal ischemic or simultaneous ischemic and hemorrhagic strokes and vasculitic changes on vessel wall imaging, varicella should be suspected. That is what I got to learn from this case. So a diagnosis of varicella vasculitis can be suggested by vascular imaging and confirmed by lab analysis, just as we saw. The treatment is usually to give acyclovir 10 mg per kg Etali for 14 days, but if the patient keeps on worsening, then it may be extended to 21 to 28 days. Recurrence rate in adults is not known. In small studies in children, the recurrence rate has been found to be 45%. It is said that it is reasonable to continue antiplatelets, especially in those who have traditional risk factors. Whether anticoagulation should be continued, it should be with caution because risk of bleeding is also there. And acute necrotizing vasculitis sometimes can happen. This patient was on dabigatran. Maybe we can rethink about that. But she was put on that because they found that every time she was on anticoagulation, she wasn't worsening. So how do we assess the response to treatment? If clinically there are no deficits and CSF is showing improvement in the pleocytosis, but it wasn't there in the beginning in this case, and there are no studies of repeat CSF analysis after treatment, and it is unclear if pleocytosis or elevated CSF IgG titers return to normal after antiviral treatment, and whether radiographic improvement occurs after acyclovir. So all those things are open for studies for us. Just a word about Zostavax immunization. In 2006, a varicella vaccine that boosts cell-mediated immunity was approved by the FDA for immunocompetent individuals over age 60 with no recent history of zoster. It is safe and effective, and it doesn't require any boosters. It is given only once after age 60. And 3-year shingles prevention study showed that Zostavax significantly reduced the burden of disease due to zoster and post-herpetic neuralgia also. So we are seeing the expanded spectrum of VZV disease. It is not so benign as our childhood immunization program would say that once you got chickenpox, you have lifelong immunity after that primary infection. Not really so, as we see the CNS involvement we have already seen in the gastrointestinal tract, ulcerative colitis, Crohn's disease, cancer rectum, gastric ulcers, all those things. So the WHO position paper, June 2014, recommends the varicella and zoster vaccines, more than 50 years, immunocompetent adult, to reduce the risk of transmission and complications of varicella and zoster. So there's a role of vaccination. One more learning that I got from this case is don't forget infectious causes of stroke even when there are no clinical suggestions for any infective cause. For we know that bacterial, viral, fungal, parasitic, whole army of pathogens is there which can cause stroke. Even sepsis can cause stroke. So I think this is the concluding slide. The purpose of presenting such unusual cases is to make us more and more conscious that these things exist. The eyes do not see what the mind does not know. And we as clinicians only know a few odd puzzles, odd pieces from the jigsaw puzzle. Surely there's much more than that meets the eye. The deeper causes of illness are yet to be known. While we wait for advancing knowledge, and science is always advancing, we are dealing with pathogens, immunity, environment, genetics, body constitution, and whatnot. But is that all? Or there's more to fathom? We know science has always more to fathom. Thank you.
My sincere thanks to Dr. Paul. I gave this as a case of CPC. I'm happy that she cracked it and then she went and elaborated all these things. Congratulations to you, madam. Thank you.
Thank you, sir. Thank you.
I'll not take more than 10 minutes. I have a lot of flights and other things. Lunch is ready. Okay. Wishing you all a happy Dashra, which is about a couple of days away. And as Parul said, what does it fathom in science? Everything is a lot of things, but I'm scared. What I'm scared is
Happy Diwali, folks.
So the A says happy Diwali, folks. And I don't know, I'm really scared because the twilights of manpower, you don't have to learn languages now. Algorithms will translate. You take any language, Google will translate it for you. You don't have to have a multiplication table, which is already the case of unanimously acclaimed millennials. I do not have to memorize anything because my smartphone is there, smarter than I am. Even I am afraid that I don't have to orient myself in space. Believe me or not, people even use GPS for everything. I do not have to choose my own bride. You can also give choices in AI, optimal, diverse free choice, heartless but more rational algorithm. I'll come back to why I say heartless. The list could continue. My brain power may take an undeserved break for many of its functions be useless, and all of us are giving almost algorithms may replace even God. Future governance should envisage all consequences outsourcing human brain functions to artificial intelligence. I'm afraid we are slowly the human intelligence is on the decline. More and more AI is. Will clinicians of tomorrow eventually become endangered? Why I say so is algorithms are now making a diagnosis. Wearable devices are making vital signs. Robots can pay remotely perform surgical procedures. The AI has been there for so long as it ascended from the AI, machine learning, deep learning, and now the GPT-4 and Chat GPT and all. The drug interaction checkers, you can do everything in the AI. And log in with your Gmail account, Gemini.google. Google has got a Gemini. And I'm seeing, just show you. I'm just writing. I think A is not married because when a wife says yes, it means no, and the wife says no, it means yes. So I think that I found out that A is not yet married. So there are different types of AI there, AI for images. And one good thing about AI is, for example, now you can generate all your images, whatever images you want now. There's no copyright on AI images, it's free. So most of your journal articles, you won't give anything, you will just do a and then do. There are a lot of animation AI artificial intelligence are there. So the open platforms are available. I'll just show you the PowerPoint presentations. Most of you'll have to figure out more. If you ask now in previous days when on the last when the chief makes the last minute, he'll say, why don't you present this tomorrow morning in the rounds? He'll say one big topic and then just walk away. Those days, at that time they used to be upset. There's no need to get upset. Nowadays, most of the presentations are only Chat GPT presentations. You say anything, it will make you 4 minutes. It makes a very good presentation. You can see. I'll tell you. Just see what's this. It chooses the fonts, it chooses the background, everything. You can choose everything in just 4 minutes. Whatever topic you. Recent updates in Europe. You can see, starting the engine, checking formats, gathering information, checking inputs, recent updates in neurology, looking forward, picking graphics. You can choose, it gives you choice also. Injecting animation, orchestrating the transition. And you can see, this is the first slide which it created. So I just wanted to show you, you can make a wonderful. So patient. So give answer. Patient had a vertigo. It is given the patient symptoms of dizziness, headache, ringing sensation. Patient presented with acute vestibular syndrome. Says possible sensitivity along with vertigo could suggest an inner ear pathology such as Meniere's. Further evaluation, these are the things which are required to go ahead. Patient just give whatever symptoms, you just put it in the GPT and this is what it gives. Just see the indication. What are the advice I should give to peripheral neuropathy? So this is where just you can take a printout and give it to your patients. That's all, everything, almost whatever things you forget, it gives you. You can see 8, 7 points on every aspect of a peripheral neuropathy it covers. Google Bard is another AI which is far more advanced, paid one. So the applications of artificial intelligence is going to be very high. The virtual, all these things already Nirmal Surya has spoken. Just what was missing is when you immerse them into such virtue that you don't have the nausea, vomiting and all before. You don't have the uncomfortable feeling of that. So what they said is, why do you want to lose that? Now there is something called sonoception technology in VR, virtual reality, which has taken the inputs of interoception, vestibular input, heart and proprioceptive. So it will give you all kinds of discomfort what you will face in a real situation. It will mimic every aspect of it, including the nausea and vomiting. So this is the technology which is, so I don't want to go into the dissections have become the VR patients, the neuro rehabilitation. Dr. Nirmalji spoke a lot about this. I don't want to go into the details except for the last, because time is nearing one. I just wanted to show you there are lots and lots of things. Neurosurgery, as you know, the robots are there. Neuro-oncology, virtual biopsies are being done now. The analysis is given by AI. Seizure disorders, there is any amount of the seizure preventive devices have come and then algorithms are there. Stroke. So I just want to close the session with only one thing. Lot of papers have increased. Telemedicine publications in neurology. This, the health information technology with iCloud, smart features, AR, VR, AM, everything. It's now technology is really surrounding you. It will immerse you. But look at this clip very carefully.
Yeah. The truck smashed our cars together and pushed us into the river. I mean,
hey, why is that? Even why is the sound? sound pa.
Yeah. The truck smashed our cars together and pushed us into the river. I mean, metal gets pretty pliable at those speeds. She's pinned, I'm pinned, the water's coming in. I'm a cop, so I already know everybody's dead. Just a few more minutes before we figure it out. And as Ford was passing by, saw the accident and jumped in the water.
You are in danger. You are in danger. Save her! Save the girl! Save her!
But it didn't save me.
The robot's brain is a difference engine. It's reading vital signs. It must have calculated that.
It did. I was the logical choice. Calculated that I had a 45% chance of survival. Sarah only had an 11% chance. That was somebody's baby. 11% is more than enough. A human being would have known that. Robots, nothing here, just lights and clockwork. Go ahead and you trust them if you want to. Let's go.
So you can see that this is going to be a ruthless future where even in ICU, you order a robo, the robo may not say that the CPR is worthless, the survival chance of the U is very less. So I am saying goodbye. So what I am tell you for the youngsters is, you can dream and not make your dreams a master. If you can think and not make your thoughts your aim, if you can use AI diligently, and you will excel in a role as a neurophysician. One could still be a man, a physician. Don't yield your analytical decision to AI, but use it as yet another tool in your toolkit. Don't give sabbatical to your innate intelligence. Thank you for your attention. Balance your AI and HI effectively. So we come to the conclusion of the edition of the Neurological Secrets. And I have the last, the valedictories, pleasant cake cutting ceremony. I request all of you to be on the stage. All of you please come to the stage. Get it organized here. Sir, please, all of you come to the stage, sir. I request Nirmalji, this is the cake, yeah? Cake. Thank you so much. The cake kahan hai? And sir, your book is this. Madam, this is. Okay, there's one more thing. Hey, I don't now want to put the video. So, madam, all of you please come on the stage, madam. All of you come, please come. All the entire neuro rehabilitation team, all of you come on the stage, madam. Madam, please stay back. Madam, please come here. The youngest person, Divya, will come and cut the cake. Come. Thanks for coming here early morning. I don't know.
Ma'am, please join us on the stage. Parul ma'am.
All of you.
Please join us on the stage.
Now no longer is secret. We always give you something. And next year, Arma madam is very interesting. She's already booked the slot. Shweta, take madam's number. And then say I'm ready. Thank you, sir. Please take a give to during the service to the lunch.
Prajakta? Please have seat. Just we are about to finish, so I request everyone to kindly sit, and I'll request Prajakta. So I request Lakshmi sir to kindly facilitate Divya for her explicitly session today in yoga. She really did well today, and we actually enjoyed our yoga session. Now I'll request Lakshmi sir for the valedictory sessions. Okay. So thank you so much, sir. Now I request Mr. Arun Chadda to please take the mic and do the closing remark.
Good afternoon to all of you. And first of all, we are very thankful to all of you to being present over here for this Golden Jubilee celebration of Secret of Neurology. It is a 4-year journey which is further going on from here also. But this is the time to celebrate the 50th Golden Jubilee. So that's why we all were here, and we are very thankful. On behalf of Intas Pharmaceutical, I, Arun Chadda, I thanks to all the delegates, those who have participated here, and those who have virtually joined us this great movement of Golden Jubilee. And further to this, I'll thanks to our course director, Dr. Sudhir Shah sir, and Dr. Lakshmi Narasimhan sir for designing such a fantastic web series, which will be very helpful for all the DM and DNB students. And further to this, I would like to thank our deepest gratitude to Dr. Vengama ma'am, Dr. Sri Ranga Lakshmi ma'am, and Dr. Aruna ma'am, and Dr. Buchiraju sir, Dr. Rajinder Bansal sir, Dr. Amit Bhardwaj sir, Dr. Nirmal Sriya sir, and all the delegates, those who have participated here and virtually. We are very thankful to all of you. And our deepest gratitude to Dr. Parul Dubey ma'am and Dr. Aishwarya and Dr. Amrut for the today's presentation, and today's the case presentation is there. We are very thankful. It was a really great presentation was there, and such type of presentation, the rare of rare presentations, that will really a good learning for all DM and DNB students, ma'am. And once again, my heartfelt thank to all of you and the participants, those who have joined virtually also. So this journey will further go ahead. Our 51st episode, that is from the Government Medical College, Guntur. They are going to present the case, next case, on 25th of October at 8 o'clock. So my request to each one of you, please join virtually in that case also. And this journey will further going on, and definitely we will celebrate the Diamond Jubilee as well as the Platinum Jubilee also for this secret of neurology. Thank you. Thank you to all of you. Thank you very much.
Thank you so much all. Your lunch will be served at the restaurant. Before that, I request everyone to kindly do the checkout because we're getting call from the hotel. Thank you so much. Thank you so much for joining us.